नहीं वो चला गया था. Mhm. So, good morning everyone and welcome to today's day with the Retina session fulfilled. I can see so many heads being all enthusiastic about Retina being taken up, right? So, let's start our session. I request Dr. Obuli Ramachandran sir to please join as chair. And he is the Vitreoretina consultant at Center for Sight, New Delhi. And he's absolutely enthusiastic and is up here absolutely on time for all of you. And because of certain delay, Dr. Chaitra Jaidev is joining us. There was some traffic issue. She's coming with us soon. So over to you, Dr. Obali sir. And he'll be talking on basic evaluation of a patient with vitreoretinal diseases, fundus diagram interactive.
Good morning. This is day 5 of a marathon for all of you. So my talk will be a very basic talk, and it will be a very asset-light talk. I'm just going to talk about, for example, history taking or basic examination of a vitreoretina patient. If you get a retina patient as your long case, so what are the things you should keep in mind or you should know about? So that will be the talk basically. It's a very light talk so that at the start of the day in this presentation, even if you remember 2 points, that will be great for your life. So now coming to the topics, the first topic is my topic will be broadly classified in 4 parts: history taking, systemic disorder, examination, and then representation. So coming to history taking, ophthalmology as in special, the history taking is a very in-depth and a very interesting aspect of your case presentation. Based just upon your history, you can weave stories upon the examiner and make him believe something which is not even there in the patient. So the history taking, the major points you have to focus is presenting complaints. What is the complaint the patient presents with? For example, in a retina diseases, most of the times the vision loss will be sudden rather than a gradual thing. Gradual thing will make you more in the line of cataract or in case of glaucoma, whereas in case of a retinal diseases, it will be more of a sudden onset drop in the vision. And then as, the duration is very important because it will help you prognosticate the patient. For example, if you are dealing with a patient of retinal detachment, the duration with which you elicit the history is very important in telling the patient how much of a vision he might be getting back after the surgery. And then the onset of symptoms, as I said, usually in retina pathologies or in vitreoretinal diseases, the symptoms of onset will be very sudden onset in nature. Be it a retinal detachment, be it a choroidal neovascular membrane, whatever it is very sudden in onset compared to a cataract. And then associated with pain. Usually the vision loss will be painless unless for example, if it is a neovascular glaucoma or else if it is a retrobulbar neuritis, those are the only 2 pathologies in a vitreoretina or neurological thing which has association with pain, or else if it is a trauma patient who has a sudden painful loss in vision. So the way you construct your history will give the examiner or whoever is listening to your presentation an idea as to where you are taking the presentation forward. And then the associated symptoms like redness, watering, and photophobia. These are 3 characteristic symptoms associated with uveitis: redness, watering, and photophobia in a vitreoretinal diseases, or in case of a neovascular glaucoma. Past treatment history. Past treatment history is very vital because whenever you are saying a patient has had a treatment before, surgery before, the duration and the type of surgery, both of them things are very important details you have to tell to the examiner, or so that they will also get into this thing, okay, this patient has already gone through the surgery, and that will also help you construct your story a little bit more coherent. And then the medication history. Medication history is very important in a patient with the vitreoretinal disease. For example, if a patient has undergone a retinal surgery, most of the time the patient will be on any long-term glaucoma medication. So that thing should be mentioned in your history only. Okay, the patient is on so-and-so drops, the patient is on so-and-so tablets. So these things are important because that will help us determine the treatment which you will suggest the examiner or which we are going to give. Now coming to the second thing, which is systemic disorder. Systemic disorder is the major systemic disorder. We will, two major systemic disorders which you will come across in vitreoretinal diseases is one is diabetes and the second is hypertension. Diabetes, you have to again say what is the type of diabetes, type 1 or type 2. It is very basic, but it is very necessary, because if it is a type 1 diabetes, you will start screening, or the diabetic retinopathy changes will come at a much early age and compared to a type 2 diabetes. And the control, always when you tell the history, you should say it like this: it's a type 1 diabetes patient with a poor control and with the recent blood report. So the regularity in taking medication and the recent blood test values are very vital. Whenever you say patient is diabetes, it doesn't stop with that. You have to say about what is the recent HbA1c level, what is the recent fasting and postprandial, so that the examiner knows that, okay, this patient is under a very poor control, okay, or this patient is under a fairly decent control. And then the medications. Always you should end any disease with the what are the tablets he is taking and what are the duration he is taking. The second disease is hypertension. Again, you have to tell about the duration, you have to tell about the hypertensive control, you have to tell about the regularity in taking medications. You also have to tell the type of medication, because most of the people say, no, I am taking Ayurveda. Ayurveda is basically nothing. So you have to tell that also, so that you basically make the examiner know what kind of a treatment the patient is taking and how regular he is with the medications. The third disease you will be most commonly seeing in retina disorders is CKD, chronic kidney diseases. Chronic kidney diseases, the most important thing you should tell about is the presence or absence of dialysis. That itself will give a gross idea as to how good the patient is controlling his kidney disorder. Or in case of a dialysis, it also helps you in plan your surgery. If you are planning a surgery for a vitreoretinal surgery for a patient with dialysis, you have to always plan it the day after dialysis, because that's the day when the urea and creatinine will be at the lowest. And also stroke history. You also, when it comes to stroke, you have to tell about the first episode. When did the first episode happen? 10 years ago, 12 years ago? The number of episodes, the most recent episodes, and the medication he is on. When it comes to stroke, a very important thing you should keep in mind is, whenever you are dealing with a patient of stroke and you are planning an anti-VEGF injection, you should always be very wary, because some studies have said that a patient with stroke has a more increased risk of a second stroke happening if you inject the patient with anti-VEGF. So that it might be a very small history. The patient may not be even showing any neurological symptoms or ailments, but still you have to ask about a patient about the history of stroke, because that will help you in your management, on planning your management. The fifth is autoimmune diseases. So the most common autoimmune diseases you will come across is HLA-B27, rheumatoid arthritis. So you have to ask the patient about the chronicity of the treatment, how long he has been, taking the tablets. Because, for example, if you take hydroxychloroquine tablet is the most common treatment for rheumatoid arthritis, but that itself is a potential toxic agent for your retina. So it's always important to calculate a cumulative dose in case the patient is on hydroxychloroquine, or if the patient is on some immunosuppressants, you should always mention that in your history. And then recent illnesses. This is mainly for uveitic condition. Whenever you are taking a history for any uveitic patients, the patient may not say it outright, like say, okay, I had a fever. You have to elicit it from the patient. So did you have any fever, 2-3 weeks? But the patient will say very non-specifically, yeah, I had some viral-like illness. So that will be very vital for you to identify. For example, if you are dealing with a white dot syndrome, prodromal illness is a very common history, but the patient may not say to you outright. You have to tease it out of the patient. Okay, so did you have any sore throat? Did you have any cough? Did you have any day of fever or lethargy? So that's how you should elicit history of recent illnesses. Other common illnesses are typhoid and mosquito-borne, which can also cause some retinitis and uveitis diseases. And the final thing is past long-standing illnesses. The two most common things are tuberculosis, because uveitis, 90% of uveitis, at least in the Indian population, has tuberculosis. Tuberculosis is a very vital disease or disease history you have to elicit. Also, the treatment on ATT and the duration of ATT. Most commonly is the drugs in ATT itself cause optic neuritis, or it causes visual impairment. So a patient who is not having any much retinal finding but is having a drop in the vision, you should always ask a history of ethambutol or history of ATT, so that will help you. So that will help you in the making up your mind as to what could be the possible cause. Now coming to the basic examination. Basic examination, any patient for long case, you have to start with vision and NCT. Vision, you just don't have to stop blindly with vision. You have to start about the vision, the uncorrected vision, the refractive error. In case you are doing a long case, it can be around straight retinoscopy, and the best corrected visual acuity. How it is important in a case with a past history of vitreoretinal diseases, your refraction will give you an idea whether the patient is having a silicone oil in situ, or because then the patient will be having a high hypermetropic power, or in case of a buckle there might be a change in an oblique axis. So all these, even a simple thing as a refraction may give you an indication as to what the patient is going through. Suddenly a patient will say that I am seeing better only with a plus glass, with a hypermetropic thing. Sudden onset, that itself could give you a possible thing that the patient is going through central serous chorioretinopathy, where the macula is elevated, and suddenly the patient will have a hypermetropic shift. And the second most important thing is intraocular pressure. Any patient with any vitreoretinal disorder, you always have to check the intraocular pressure, because the patient may be having a coexisting glaucoma, or the patient may be having a secondary glaucoma post a past history of vitreoretinal treatment. Now coming to the next thing, which is basic examination. Basic examination, you should always start your presentation by saying about torchlight examination. Most of the people will suddenly say, okay, slit lamp examination, but first you should start your examination with the torchlight. And the most important thing you have to see is direct and consensual pupillary reflex. And the other thing which you might be missing out most commonly is proptosis, because in a patient with vitreoretinal disorder, there might be history of buckle, there might be history of thyroid thyroid related eye disorders. So that itself you should actually tell, or note all those findings in your exam, in your long case, so that will give a vital additional points as to what we are dealing with. Now coming to slit lamp examination, you should always start from the conjunctiva. Us retina people, we most of the time don't see the anterior segment. Only if we see some media haze, we come back and see what is there in the anterior segment. But it's always vital to see what is there in the anterior segment, and it starts with conjunctiva. In case of conjunctiva, you should not see barely only the bulbar conjunctiva. You should avert the eyelid and see under the palpebral conjunctiva, where there might be a history of buckle. You might be seeing the buccal sutures. There might be band sutures. There might be past scars, like wherever the port was made, there will be scars. So this itself, sometimes the patient might hide, or might have forgotten his history of retinal surgery. But you, while examining, you can identify what kind of the retinal surgery has already happened. And then coming to cornea, mostly in retinal pathology, cornea might not have that much findings, except for some scar, like if the patient had any open globe injury, there might be a scar of the sutured cornea, or in case of secondary glaucoma, there might be a microcystic or stromal edema. Coming to anterior chamber, you have to look for the depth, the uniformity of the depth, and then the cells, flare, and then most common thing you will notice in a post-VR patient will be emulsified silicone oil, and in a case of a traumatic patient, you will be seeing hyphema. Then coming to iris, the most important aspect in any retina or slit lamp examination is for you to document the presence or absence of NVI. And NVI is always to be seen in an undilated state, because the moment you dilate, it will be very difficult for you to identify or to search for an NVI. The other findings you might be seeing is traumatic sphincter tear. In case the patient has a history of trauma, you have to note the you have to see for a traumatic sphincter tear. Iris chafing, if the patient had a complicated cataract surgery, there will be iris chafing. That itself will give you an idea, okay, was there any iatrogenic trauma to this patient. Traumatic mydriasis, that also is another vital thing you have to see. And iridodialysis. Iridodialysis, you have to mention the clock overs and the how much width of clock overs it's there, and what quadrant it is there. Then coming to the lens, there you have to mention look for the type of cataract. You have to look for the stability of the lens. You have to look for the lens touch. So this is something, if a patient has a history of multiple intravitreal injections, then you have to always look for a lens touch, because if the cataract surgeon is planning his cataract surgery, that is a potential area for a PCR to happen. So you have to look for lens touch for your needle tract injury, and then you also have to look for zonular integrity. In case of intraocular lenses, you have to look for the type of intraocular lens, the PCO, the stability of the intraocular lens, and the fixation of the lens. In case of a scleral fixated IOL, you will be seeing the haptics coming out through the beside of the limbus and into the sclera. So that also can give you a history as to what the patient has undergone. And then finally, the anterior vitreous phase. AVF should be your last finding in any slit lamp examination. You have to look for the cells, you have to look for the number of cells, and also you have to look for siliconal bubbles also. Now coming to gonioscopy. Gonioscopy you should do in a patient where there is any history of glaucoma, or in case you suspect any neovascularization. So you have to look for neovascularization of the angles, you have to look for emulsified oil, you have to look for angle recession in case of a traumatic patient, and synechia. And finally you have to look for slit lamp biomicroscopy. So in case of a slit lamp biomicroscopy, the most, whenever you say about your disc and a macula, describing your disc and macula to your examiner, you should always say, okay, I saw the patient's disc and macula via 90 diopter lens, and then these are my findings. Because in an indirect, if you are doing an indirect ophthalmoscopy, the disc and macular findings may not be that well defined. So you should always say the 90D findings separately and the indirect ophthalmoscopy findings separately. Now coming to indirect ophthalmoscopy. So indirect ophthalmoscopy is the crux of a retinal examination. So any patient, you have to have a thorough, detailed indirect ophthalmoscopy examination. So coming to indirect ophthalmoscopy, preferably you have to be in a dark room so that the patient, there is no other additional glare. And then the patient is preferably lying down, because in sitting position for you to examine different quadrants will become very difficult. And preferably if you have a height adjustable chair unit, it will save your own backs, because bending over a patient and trying to see will cause you very severe back pain in the long run. And then adequate space to move around the patient, because it doesn't necessarily mean that the table should be towards the floor, one wall, because then the examination will become very difficult. There should be adequate space on either side of the patient's head for you to see all quadrants. And then always ask or encourage the patient to keep his other eye open, because most of the times when the patient, bright light falls in the eye, he will start squeezing his eyes, then it will be very difficult for you to see all quadrants in detail. And finally, a proprioceptive target. As in this diagram, you have to always give thumb as the the potential target for the patient, because even if the patient is not able to see anything in a dark room, his thumb is a very good proprioceptive agent that will itself will ask the patient to look in that particular direction, and opening his both eyes, that will help you in examining the patient very easily. Now coming to the type of indenters, there is a curved indenter, there is a stick indenter, and there is a cotton bud. So curved indenter is the most common indenter you will start working with in your PG life. There is also a stick indenter, and in case of a pediatric child, or if you don't have any indenters, you can even use something as simple as a Johnson & Johnson cotton bud. Any cotton bud can also be used to indent your ora. So the technique of holding an indenter, there are two techniques. You can either hold the cup as a whole with all your fingers, or you can insert it in one of your fingers. That will be an easier way to hold your indenter. And now coming to the technique of indentation, while make the patient lie down, and then as wherever quadrant you are going to indent, first ask the patient to look in the opposite direction, and then first gently insert your indenter into the into the crease, lid crease, and then you ask now the patient to look in the direction you want to be indented. For example, if you are indenting the superior superior quadrant, first you ask the patient to look inferiorly, you insert the indenter into the lid crease, and then now you ask the patient to look superiorly, and then you just have to gently roll the curve over the orbital rim, and now you will get a very good indentation. And then now coming finally to the representation. Representation is a very important thing. Whenever you are representing your diagrams in the retinal thing, you have to be very clear, and the diagram has to be very beautiful in case of, or you impress the examiner. So now coming to the, this is a modeler's modified Amsler-Dubois chart. Now coming to the basic thing. So the Amsler-Dubois chart has three rings. The first ring is the ciliary process region. The area in between the ciliary process region and the ora serrata is the pars plana. The second ring is the ora serrata, and the third ring is the equator. So this is very vital for you to, for example, in case of a choroidal detachment, the choroidal detachment never crosses the equator. So whenever you are making a CD, you have to be very sure that it only crosses, your diagrammatic representation should only be in front of the equator. It should never cross the equator. Now coming to the other common, retinal findings. Coming to the peripheral retinal degeneration, the most common is lattice degeneration. So how do you make a lattice degeneration? You have to make a oval, some oval peripheral lesions. If the crisscrossing is with red, then it is in an attached retina. If the crisscrossing is in a blue, it is in a detached retina. And coming to the HST, other most common peripheral lesion you will be seeing across is horseshoe tear. Horseshoe tear will be like a blue color horseshoe shaped lesion with a central red line, which means that you are able to see the choroid in between. And then retinal hole is similar, a blue color outer margin and a red color inner shading. And then if you are coming to the paving stone degeneration, you have to in between, instead of shading it throughout your lines, there should be lines in between, straight lines. That will be mean a paving stone degeneration. And then coming to the other peripheral thing, if you are want to represent a scleral buckle or a scleral band, there should be a brown color line, and then there should be semicircular lines, concentric semicircular lines that represents a band. And then in case of a detached retina, and attached retina is very common, attached retina should always be represented as red, and detached retina should always be represented in case of a blue. And then how do you represent a star fold? A star fold should be a cross, shaped with multiple lines. And then if it is a single line cross, then it means a circumferential fold. And then if there is a line of crosses, then that means a circumferential traction. And then in case of a dialysis, the dialysis should always be connected to the ora serrata. So whenever you are making a dialysis, the ora serrata should always be connected along with it. In case of any foreign body, you should always color it with black. If in case of an intraocular lens, you will color it with a green. And then in case of a vitreous hemorrhage, you should, again, any media haze, you will be coloring it as green. And then retinoschisis, there will be two intersecting crisscross lines. If there is a retinoschisis, you should always mention it instead of a single line, it should be two intersecting crisscross lines. And then in case of a retinoblastoma, it should be denoted with yellow color line with a black color outer margin. And in case of a coloboma, it will be just yellow color line, there won't be any black color outer margin. And then in case of a subhyaloid hemorrhage, you should always mention it, make it boat shaped. That's how you will differentiate a vitreous hemorrhage and a subhyaloid hemorrhage. In case, so now coming to the macula, attached macula will always be a red color plus, and the detached macula will be a blue color plus. And in case of a cystoid macular edema, you should make 4 circles around this plus, which means there is a macular edema. If there are any exudates, hard exudates, you have to make it in a yellow color. And in case of a CNVM, there will be a plus red color and a yellow color, so it has an exudative and a hemorrhagic component. And then neovascularization, if there is a raised neovascularization, you have to make it in a flower shaped thing with a red color line. And in case of a flat neovascularization, you have to make it in a blue color flower shaped lesion. Coming to the sheathing, so any vessel, if it has sheathing, it should have a yellow color line which is around this lesion. And in case of a sclerosed vessel, it will be like a broken lines. That denotes a sclerosed vessel. So now coming to a model this thing. So in your exam, if you have a long case, you should always mention 2 things. The eye which you are going to present, that should be in the major diagram, and the other eye should also be mentioned in this as a minor diagram. So in this case, this is a total retinal detachment with multiple subretinal bands and peripheral. There is you can see all these crosses. So there is a peripheral circumferential traction, and then there is a subretinal band going beneath the fovea, and then the other eye is also having a subclinical RD inferiorly. So this is how you should represent your diagrams in the final exam. And that concludes my presentation. Thank you.
Thank you so much. Any questions from any of the postgraduates? Anything that you would like to ask in specific? Or maybe if you can just add a quick word on examining pediatric retina.
Pediatric retina, basically you have to first, most commonly pediatric retina we will be seeing is either ROP, or in case of a 6 to 8 year old child, it will be very difficult. In case of an ROP, you should always ensure that the child is very well covered, it is very warm, and you should always have a pediatric ROP set which has a different kind of a lid speculum and a different shape of indenter. And the eye should always be anesthetized. The child should always be well held, and 2 attenders should be holding the child, and you should always be using a bud to indent the thing instead of your traditional indenter, a bud, because the eye is very fragile. The indentation part should be done very gently, or else there will have a lot of subconjunctival hemorrhages.
Yeah, great. So those are some pointers, and you will be seeing pediatric patients in your practice, not only importantly ROP, as Dr. Obli mentioned, but also, sometimes you may need to examine them when they come with a white reflex. You want to make sure what the condition is, whether it's retinoblastoma, coats. So multiple cases. In adults, it's always easy to examine, but in kids, it's a big challenge. So like Dr. Obli mentioned, you have to stabilize the child, preferably wrap the child so that the limbs don't affect you as you're examining, and the head can be either stabilized with an attender, the mother, the parent. It's always difficult to examine a child when the parents are there, because the parents are more apprehensive than the child, because the child is going to cry anyway. So if possible, try to examine the child in a separate room with an attender to help you out. Yeah? Thank you.
Thank you, ma'am.
Thank you so much, sir. And that was really like the perfect start and for the keeping the base for the day. And I want to now know how many of you like to read an OCT or know how to read an OCT. Raise your hands. Okay, so that lane knows it well, for sure. And how many of you are okay with OCT angio? No? Okay, so electrodiagnostic tests? Okay, so how many of you have it over there at your centers and you're able to at least see these tests? Yeah? Okay, fine. And what about FFA, ICG and FA? You guys have that? Okay, so what this session has been specifically put across to you guys, because this is an interactive session, right? So in the interactive session, they're just going to try to display and try to teach you regarding different tests which are not available at your center, right? And that's okay, it's fine. But it is very important to understand all these tests to be able to go ahead with diagnosis of the diseases. So if you don't understand this segment, then the entire day for you will kind of go above your head, right? So I welcome the next speaker for the day and the chair for the session, Dr. Chaitra Jaydev. She's the head of the Vitreoretina services at Narayan Nethralaya, Bangalore, and with special interest in research. So most welcome, ma'am.
So good morning, everyone. Nice to see you all cheerful and ready for the day ahead. I'm sure it's been a great learning experience so far. So till we get connected to the laptop, can we have a show of hands? How many of you all actually have access to an OCT in your hospital? Oh wow, that's almost everybody. How many of you have access to an OCTA machine? Okay, that's less. So what we'll do is we'll keep the OCT interactive, because I know it's going to be tough for the OCTA for you all to interpret it. And how we'll go forward with this talk is, I know the names of only 5 people in this audience. I can count my friend there, and I know him, and I know Rolika and myself, and probably one other person. So I don't know who you all are, from where you all have come, and I'm never going to remember whether you identified the OCT correct or not. But you'll have to make an attempt. Okay, the time you make the effect, it is more effective in you remembering what you saw, what you learned. Okay, so for OCT, we'll go interactive. I will show you all very, very simple images of the scan that we have taken. All you need to do is tell me what you think it is, and then we'll figure out whether it's right or wrong. Okay, and I think even without the mic, most of you all would be audible. Okay, so we're doing OCT and OCTA and retinal pathologies, when to advise and how to interpret them. No financial disclosures. So OCT, as we all know, is a non-invasive diagnostic imaging technique which takes cross-sectional images of the retina, and it is based on the optical interferometry or low coherence interferometry. So I'm not going to go too much into the theory, because it's there in all your books and you can just download and read it if you want. So we've seen a major evolution in OCT, and we're continuing to see OCT. And now we have OCT that's gone into OCTA. We have several different advances in the field. In 2014 is when the first commercial OCT came into the picture here, and we have the commercial OCTA also coming in 2014 there. So these are the different types of OCTs that were available. So when I started learning my retina practice, it was actually time domain, which has now grown into spectral domain, and then SSOCT as well. So these are the different features that differentiate between each one of them. Of course, swept source is highly advanced. You have high resolution images in that, when you don't even need to differentiate between the layers, everything is so well delineated. So this is your histology. We all know the different layers of the retina, and you have the OCT here. So how do these two correlate? Why is OCT actually a reflection of your retinal histology? Is because every layer in your histology is represented in the OCT. So it's as simple as that. So the minute you read your OCT, you actually know which layer of your retina is affected in that particular patient. So you can actually see each one of the layers. This is the inner retinal layer. You can see how the NFL correlates there to the ILM, how the ganglion cell layer is seen, how the bipolar, the photoreceptors, everything is seen in the inner retina, and likewise in the outer retina. So you can actually tell, okay, the photoreceptors in this patient with dystrophy is affected, without even having to probably do an electrophysiological test. So a lot of our dystrophy patients now we are able to diagnose with just an OCT. So this is the device that I have at my center, and most of the images would be from this. This is a Spectralis device. They have different scanning protocols. You will have rasters, you will have line scans. So all of them help in getting either better resolution or actually to locate the pathology in that particular patient. So you also get a thickness map like this, and this is extremely useful when you actually want to follow up this patient post treatment. So you know it's a 651 microns here, whether the drug has affected the patient positively or not, what is the reduction in the thickness. You also have this map where you can see where the edema is distributed in a particular patient. So how do you interpret the OCT? What are the most important things that you need to see is determine why the OCT was even done, whether it was done for the macula, whether it's done for the OCT, whether it's a retinal OCT, whether it's a glaucoma OCT. By just looking at the scan, you'll be able to determine. Next, look whether the proper scan protocol was used for that particular patient, because if it is not, you might probably ask for another scan. Identify artifacts, because many a time we tend to call the scan abnormal just because there was an artifact there. Make sure, and what happens with artifacts is you'll see it at every scan. You know that exactly at that place that lesion is there, that means it's an artifact. It's a simple way to figure it out. Next, evaluate each layer. You start from the posterior vitreous up to the choroidal scleral junction. So that's very visible in the EDI scans. You'll be able to even see the choroid there very well, see the thickness of the choroid as well. So see each layer so that you don't miss anything. And then you classify the abnormality. How do you classify it? Whether you want to look at it, the contour, you want to look at the thickness, you want to look at the reflectivity, whether there's any loss of tissue, in macular holes, you will see loss of tissue. Look for presence of abnormal tissue. Abnormal tissue could either be fluid, it could be blood, it could be exudates, it could be so many of these things. So identify the abnormal tissue and look for the location of the abnormality, because this actually is a very, very good prognostic indicator. If you see that vital layers of the retina are affected, that means the prognosis is rather poor. You'll also be able to plan surgery based on the location of the abnormality. What are the layers involved is also again very, very important. So this is how the scan printout comes. Identify the patient's name, the age, the gender, identify which eye the scan is. More or less you have the fundus image, the macular image right next to it, so you will even know which eye it is. Look at the signal strength, because sometimes you might miss something subtle if the signal strength is poor, and these are the different layers that you will start identifying. So you see the pre-retinal, you have the epiretinal, you have the intraretinal and the subretinal layers. So to give you a simple indication of what is hyperreflective and what is hyporeflective. So what I've given above is actually the normal layers. In the hyperreflective, you have the ILM, you have the RNFL, you have the IPL, the OPL, ELM and EZ, you have the RPE and the RPCC complex. So these are all the normally seen hyperreflective layers. The hyporeflective layers are the ganglionic cell, the INL and the ONL layers. So all the nuclear layers are mostly hyporeflective. Okay, so this is simple. Once you know this, you know exactly what layer you're seeing. Now, what are the hyperreflective abnormal structures? Are drusen's, you have epiretinal membrane, CNVMs, disciform scars, hard exudates. This is not an all-inclusive slide. I've just put common ones. And for hyporeflective, it's mostly fluid or blood. You can see it in the intraretinal or the subretinal space as well. So here I've put in two abnormal images. What could be abnormal? Anyone? In the image above? Cystoid spaces. So that is hyporeflective. We just saw that intraretinal fluid can be hyporeflective. So you have cystoid spaces. What about in the image below? You see something hyperreflective. What is that? Those are hard exudates. So when you see reduced reflectivity, is retinal edema, subretinal or sub-RP fluid. And when you see increased reflectivity, it's either a vitreous membrane, when it's preretinal. In the image below, you can see that membrane, right? Do we have a pointer? Okay, so can you see that thin layer there? I don't know if I can show you on this. There, see? That's in the vitreous. So what is that? Yes, so you can see the vitreous membranes. You can see epiretinal membrane, CNVM, hard exudates, calcification sometimes, and hemorrhage and fibrosis as well. So some of our uvea colleagues even can pick out cells. I don't know how they do it, but I'm sure when you have high resolution SSOCTs, you can even pick up inflammation on the OCT. Now let's go to the vitreomacular interface. Now this is when you guys are going to tell me what this is. Let's start with the first image. What is this? Epiretinal membrane. Very good. What else do you see there? What about the outer retina? Do you think it's good? Is it healthy? Yes. So there are actually back shadows. The external or the outer retina is actually quite good there in this particular patient. Might help with surgery. So like I said, you're not only doing these scans to determine the diagnosis, you also want to know the prognosis if you're planning to intervene in these patients. What about this patient? What do you see here? You're seeing an epiretinal membrane like you said before. What else do you see? Excellent. Hyperreflective dots and cystic spaces. So tell me something. In this patient, you're seeing CME, and the treatment for CME is usually giving injections. So will it help in this patient? Why not? Exactly. So when you also have an epiretinal membrane, it may not always help, but a trial of injection maybe is still warranted. If the patient just does not improve because it's not a very thick membrane and there's no traction, you can still give a trial of injection. If the injection doesn't work, you know why it's not working, and you've already showed the patient, you know, why it could not work also. So this patient, would you operate or not? Again, epiretinal membrane, all of you will agree? Will you operate? Why will you operate? Good. Yes. What is the indication for surgery? Do you see the foveal contour? It's lost. Yes. So the foveal contour is lost, so potentially the patient does have poor visual acuity, but good prognosis because the outer retinal layers are intact. So yes, we operated on this patient, and this is the post-operative picture. Patient is doing extremely well. So like I said, diagnosis, prognostication, planning of surgery even, and whether you want to give any adjuvant drugs during the surgery, pre-surgery, post-surgery, you want to give them an intravitreal steroid. If there's a lot of edema, you can plan accordingly. What is this? VMA. So you can see these two, points here and here. You can see it's almost getting pulled up there, but it's not yet pulled up. So vitreomacular adhesion. What about this? Yes, you can see there it's already being pulled up. You can also see what other spaces are there. Cystoid spaces there. What about this? What is the difference between these two? What is the difference between the image on top and the image below? Do you agree, all of you, that it's a VMT? Yes, so it's a VMT. What is important here is you actually have to classify it based on focal VMT versus broad-based VMT. What happens in focal VMT is, if in case the membranes separate, you may avoid a surgery, but with broad-based VMT, mostly they will require surgery, especially if the traction continues to worsen. So the image above, if you see this patient, actually eventually the membrane separated out and the patient's vision actually improved, whereas the one below underwent surgery. Okay, now what is this? Lamella macular hole, very good. And what is this? Pseudo hole. So anybody wants to tell me quickly what is the difference between a lamella macular hole and a pseudo hole, because this continues to confuse even our fellows now. Most often they are unable to differentiate. Tell me the differences. Okay, I can't hear all of you all. But anyway, so to differentiate between these two, in a lamellar macular hole, you actually have loss of the inner retinal layers. That's very important. Whereas in a pseudo hole, you don't have any loss of tissue. Mostly what happens in a pseudo hole is that there is centripetal contraction of the ERM that causes verticalization of the edge of the foveal pit. So, what normally you see as a smooth contour of the foveal pit becomes vertical. It could be either U-shaped or a V-shaped, but there is no loss of retinal tissue. That is the most important thing in pseudo hole. So, you have a lamellar hole versus a pseudo hole. These are again some of the differences between the two. There is intraretinal splitting with separation of the inner and outer retinal layers also at the fovea in a lamellar macular hole, as you can see in that picture there. But there is no full thickness foveal defect. What you would call a full thickness foveal defect? Full thickness macular hole. Excellent. So, what is this? I am just showing you a series of pictures. What do you think you are going to expect next? Full thickness macular hole. Very good. So, I am not going to go into the theory of full thickness macular hole because there is a lot and it will be impossible for me to cover. Let us go next to some other important features. What is this? Cystoid macular edema. Anything else you can see there? What do you see in the vitreous? Yes, you can also see the membrane there attached right at the fovea. So, let us quickly look at the OCT classification of DME. It is very important because all of us treat DME based on OCT now, whether it is to classify the type, whether it is to decide which medication to give, whether it is for follow up, and whether it is to teach a patient on whether it is to prognosticate. All of us, so many times, in fact, we even ask for the OCT even before the patient walks into our clinic, so that it is easier for us to explain to the patient. So, you have the spongiform thickening or the diffuse thickening, you have the CME. Do you all know this classification? You have to know this classification. Okay, you have serous retinal detachment or an NST, you have VMT without any traction, but then you have also with the TRD as well. So, let us look at some images. What is this? This is spongiform, it is diffuse thickening, you can see a couple of cystoid spaces there. What about this? Cystoid. What else do you see there? Hyperreflective dots or hyperreflective foci there. Cystoid. I would prefer to give a steroid in these sort of patients because the edema is so much more. It will take 3 or 4 anti-VEGFs before the edema comes down, and because of the hyperreflective dots, they are supposed to be an indication of inflammation. So, maybe a steroid will help in this particular patient, of course, provided the patient does not have glaucoma or no risks to have a glaucoma. What about this? What do you see there? So, this is a neurosensory detachment and that is where your detachment is. You can see that very clearly now. Next, what about this? So, here there is a VMT, but there is no really TRD because it is not yet separated there from the layers. So, this patient also underwent surgery because it was a one-eyed patient, patient was symptomatic, and this is post-op. So, it is not necessary that only when you see TRD progressing, sometimes in a one-eyed patient you may need to take a call just to prevent it from going into a TRD, because once the TRD goes, obviously the quality of vision is going to come down. So, this is a TRD. You will see a lot of traction there, the retina is actually quite elevated. So, this is a patient with VMT and a tractional component there as well, a TRD. So, this is post-op. What is this? CRAO. Okay, I heard someone there, CRAO. So, this is a patient with CRAO, and this is another image with CRAO. So, basically you see this inner retinal whitening and you see sort of a halo outside, as you can see there. So, this is an acute phase of CRAO. Eventually the retina actually gets completely thinned out. So, when you see an OCT and all the layers become very compact, so then you know it is an old case of CRAO, even though the patient just comes to you probably 6 months after. You can still clinically there is no cherry red spot, you can't really make out anything, but you will still know once you see it. So, this is a image of this particular patient whose OCT I showed you. What about this? This is very interesting. BRAO, very good. I heard someone saying that. You can see one side of your OCT is absolutely normal and on the other side you see whitening there, and this is the clinical image of this particular patient. What about this? CME, and cause is CRVO. CRVO, CME, you can see an equal distribution of the edema across the fovea. On either side, you can see the edema. What about this? BRVO. So, with just looking at it, you can say it's a BRVO potentially, because one side of it is absolutely normal and the other side you can see edema. You can see unequal distribution of the edema. So, looking at the OCT itself, you can say it's a BRVO, and that's the clinical picture in this particular patient. So, in retinal vascular disorders, it helps us in retinal thickness assessment or the edema, the patterns of DME, the treatment protocol for DME itself you can decide based on the OCT, quantification in vein occlusions, because we see edemas of 800, 900. Patient will never understand unless you show the OCT and say your edema is 900, normal is 250 to 300. You are going to need multiple injections, because this one question the patient will ask you every single visit is, how many more injections? Why did this happen? These two questions they will ask you forever. So, you be prepared for that, and monitor response to treatment as well. So many times they don't respond. It also helps to show the patient, see, this is your last scan, this is your current scan, you have not responded, hence I have to switch the medication, and prognostic indicators that we spoke about. Now next, what is this? I can't hear you. Drusen. So what could be the diagnosis? What type of ARMD? Dry AMD. So this is another patient with a similar picture here. So here again in dry AMD, it helps us to see the extent of the disease. You can see how different it is for the patient above and the one below. You can look for progression. You can even talk about the prognosis in these patients. What is this? No, it's not CNVM. Why? Scar due to geographic atrophy. Okay. So, since we are on the topic of AMD, we are also covering what can be the extreme end stage of patients with dry AMD. So, like I said, prognosis can be given to these patients. You can actually tell them without mincing words that their central vision is not going to come back. This is something that you have to tell them, because unless you tell a patient that clearly, yes, there will be tears, there will be anger, but they will go to 5 other doctors and then they will go to Ayurveda, they will spend 20,000-30,000 a month. So, you need to tell them that there is as of now no treatment available, the new trial that has happened, but you know the results are not very great. So, you need the most important thing is to give the patient clarity, so that they don't keep hopping from one city to another or doctors within the city itself. What about this? So, we saw drusen. What else is there? SRF is there, and you can also see something like a membrane forming there. It could be hemorrhage, it could be a new membrane forming. So, this is a wet AMD or an exudative AMD. So, in a exudative AMD, you can see the type of lesion, you can see the location, the extent, you can correlate with dye-based angiography, you can see whether there is subretinal fluid, intraretinal fluid, because all these fluids are what you can measure. You want to look at SRF, IRF and sub-RP fluid, the types of PEDs, the response to anti-VEGF. So, this patient was given an anti-VEGF, and this is actually the 1 month follow-up. You can see how dramatically the lesion has started responding. So, in non-exudative, you want to look at the extent, the disease progression, the staging and the prognosis. In exudative, I just mentioned what all we will be looking at. Now, what are these? PEDs, right. You have 3 types. Anybody wants to tell me? Excellent. So, you can also see the different types of PEDs. You know which PED you can actually observe, which PED you need to call sooner, and which PED you treat, right. So, all of them are very, very important. So, this is a PED. What are you going to do with this PED? There is a PED here. What else is there? CSCR. You see CSCR and you also see a PED there. So, EDI scans have become extremely useful in this pachychoroid spectrum, as we call it. I can't cover it in this lecture because it will be too exhaustive, but there are many patients whom we used to think as CSCR and continue to observe them, but they actually had a pachyneovasculopathy and we treated them with injections and they did well. So, the important lesson here is OCT is going to help you all. In this particular disease, what we used to think CSCR is no more just plain CSCR, where you tell the patient go do meditation or yoga, you know, take a break, take a holiday, de-stress, walk, listen to music, doesn't work. You have to actually call them more frequently to ensure that you have exhausted all treatment options, because most of them are very young. So, here there is a PD and there is fluid. Is this CSCR? This you said PD and fluid, right? So, the previous patient had CSCR. So, it is not. These are patients who have now have a condition called as PCV. Excellent. So, this is thumb like PDs, you have notched PDs, you also have double layer sign. So, more and more now PCV is being diagnosed by OCT. The new PCV guidelines say you can do away with ICG, because ICG is not as easily available as an OCT. OCT, every practitioner literally has it, including a cataract surgeon who wants to do a pre-op OCT just to ensure that everything is going to go fine in their premium IOLs. Okay? So, you are going to have access to OCT. Please learn how to identify this particular condition. What about this? What could the patient potentially have? High myopia, very good. So, these are some of the images here. Sometimes you need to just observe, sometimes you need to even operate these patients. It is not always easy, because they have such a large axial length and a posterior staphyloma that is not always you know, successful to operate these patients. So, this is myopic tractional maculopathy, and what you can identify on OCT is staphylomas, hemorrhages, scars. Myopic CNVMs are very, very subtle. Clinically, it's impossible to diagnose it unless, you know, they have some hemorrhage, because the contrast is poor, they have a highly tessellated background. You may not be able to pick it up, but the one thing you have to remember about myopic CNVMs is the patients are very, very symptomatic. Even with a tiny lesion, they will come to you and say that something is not okay. And likewise, they are very responsive to treatment. Mostly with one injection, they settle down. So, you can pick this up quite well on the OCT, or sometimes an angio is required. Macular and lamellar holes you can pick up, ERM. So, all this is definitely helpful in patients with myopia. What is this? It is a tough condition. What do you see there? What do you see near the ILM? Very good. So, you see the ILM drape, you see the ISOS disruption, you see a temporal enlargement of the foveal pit and foveal atrophy. So, this is again a very devastating condition, because most often there is no treatment unless the patient develops, you know, neovascularization. And it is also important because it is seen in patients who have low vision. They think it is because of cataract, they operate the patient, but then the vision never improves. So, always good to document this pre-op to tell that your improvement will be subnormal, right. What is this? Excellent, yes, photic solar retinopathy, again poor visual recovery post cataract surgery. Unless you document it, you could be in legal trouble as well. They will say, no, you did this because of cataract surgery, I was fine. So, unless you have a documentation like this, you are never going to be able to prove it to the patient that this is the reason for the poor vision post surgery. Okay. Okay, so now we will go over to OCTA. Any doubts with respect to OCT? No, I have not covered all topics, but I will give you a list of things that you can potentially cover, like biomarkers, those things it is not possible to cover. So, in the next 5 minutes, I am going to quickly go through OCTA. So, there has been an evolution of OCT to OCTA itself, and we have this particular device called as the OptoView since 2013. So, we as a center at Narayana Nethralaya have done quite a bit of work on OCTA, and we have been able to show how actually dye based angiography can be replaced by OCTA in certain indications. It is not possible to do it in all patients. Why has this transition been possible, and why have we started using OCTA more frequently is that it is non-invasive, you can do it quickly, you can repeat it, forget once a month or once in 2 weeks, you can repeat it 3 times in a day. If you do not find it and you want to go back and do the segmentation, or you want to retake the image, you can do that, but you can never do that with a dye based you know, angiography. And so many times we do have patients having reaction to the dye, so you can do away with the dye. Having said that, it is not that you can replace angiography with OCTA, but like I mentioned, certain subtle lesions like myopic CNVMs, when you want to actually pick out a lesion or neovasculopathy in a patient with CSCR, CNVMs, you do not know whether it is a scar or it is active. Even in PCV, OCTA has become very, very helpful. So, which are the different devices? You have the Topcon, you have the OptoView, this is what we have. Other than that, you also have the Spectralis device, though we are using the OptoView more. And then you have the Zeiss series, also very popular. You also have the Plex Elite from the Zeiss, we don't have it, but it's a fantastic OCTA device. And then you also have the Nidec devices. So, these are some of the OCTA, I am sure there are more, but they keep getting upgraded from their OCT machines to become an OCTA. Okay, so there are different principles. You have the Avanti, which has the SSADA algorithm, you have the Heidelberg, you have the OMAG on the Zeiss Angioplex, and each one of them have different algorithms, which actually speaking we don't really need to break our head much on. But as long as you learn a little bit of the interpretation, and what is the principle here basically is that it looks as motion. Motion of what particular structure? RBCs. So, you use the algorithm to basically pick out the reflection from the blood cells, and that is detected basically by sequential OCT B scans, and when you do it repeatedly at the same location up to 4 times, you can actually pick out the reflection of the light, and then you identify the blood flow in these particular patients. So, when you segment, you have the superficial capillary, you have the DCP, you have the outer, and then you have the choriocapillaries. So, how do you identify that it is a superficial plexus? Basically just look at how the blood vessels are distributed. Suppose somebody just gives you this image, how do you know it is a superficial plexus? Is because it has a centripetal pattern of the foveal avascular zone. Around that you see the blood vessels are centripetal. You have a continuous perifoveal arcade with regular meshes. The offset is from the ILM to the IPL. What layers you can actually see here are the RNFL, the ganglion cell, and the superficial inner plexiform layer. So, if you can tell these many points about the SCP, it is more than enough. Going on to the deep capillary plexus, again if you see here, look at the way the vasculature is, it is so much more compact compared to the SCP. So, here there is a more close knit pattern of the vessels around the avascular zone, the offset is again from the IPL, What layers that you see here are the deep inner plexiform layer, the inner nuclear layer, the OPL, and the superficial outer nuclear layer. So, that should, and then you have the outer retina. Normally you do not see any vascular plexus at all. Here you see the deeper outer nuclear layer to the external limiting membrane. And lastly, you have the choriocapillary. So, this is what you will be focusing a lot when you see the CNVMs here. It has a very coarse structure, as you can see here, not too many blood vessels as you saw in the SCP and the DCP. So, you also have flow density maps, you have the flow area that is calculated and the non-flow area calculated. This is basically the flow area when you are looking at neovascularization, and the non-flow area when you are looking at ischemia, simple. Okay? And they can be quantified, which you can't do with dye-based angiography. That is one single advantage that you have here with respect to quantification. The quantification is actually done on the machine itself. So, I am giving you a simple example here. You can see the angiography and how it is leaking, whereas on the OCTA, just see how well you can delineate the network there, and then you can actually see the vessels are growing into the vitreous. So, beautifully you can demonstrate the new blood vessels here, and once you do the PRP, you can actually show regression. I mean, I am not putting those images, but you can actually show that the neovascularization is completely regressed. So, this is again what you can see, an area of no flow or non-perfusion and an adjacent area of a neovascularization. So, as you know, where you see CNP areas, adjacent to them are the neovascularization. Again, like I mentioned, you can map the CNP areas. Quickly some case examples, these are dry AMD. You can see drusenoid PEDs in this patient. Again here you can see geographic atrophy, you can see like a barren tree appearance there, tree without branches there, that is a GA. This is a CNVM, I just want to show you the correlation, how good it correlates with the dye-based angiography. This is a type 1 and a type 2 CNVM. I mean, I do not have access to an SSO OCTA, but this is seen quite well. And then you see also scarred CNVM. So, I am going to quickly rush through. What is important here is that you can actually show how the membrane has started shrinking. Quantify the membrane. This is PCV. I just wanted to show you how you can actually pick out even polyps and a BVN as well. Shall I end now or should I just rush through a couple of slides? I'm good to end. So, because this is a little difficult for them to understand octa in such a short interval, but I'm just going to run through. So here you can see the FAZ well delineated even on the octa, which you would probably have used an angiography for. This is MACTEL. This is a patient, how you should differentiate from a CSCR, and post injection patient actually responded well because there was a neovascularization. This is interesting. What is this? CRAO. So this is the angiography, and this is just post paracentesis. So like I said, in the same day, if you want to do it, you can actually show reperfusion after doing a paracentesis. High myop, this was a CNVM we picked up only on octa, patient responded. We have done octa even in a patient with ROP, a small baby, and we were able to show how the neovascularization actually goes into the deeper layers here. So this is the plex elite. I'm just going to show you images of this. Is a moderate NPDR suspected patient, and when you do a montage of the plex elite, you can actually see neovascularization there and non-perfusion without even doing a dye-based angiography. So this is pre and post injection actually in this particular patient, where you can actually see regression of the neovascularization. So these are my last two slides. This is the advances in octa that you can see, and they have done 3D rendering where you can actually see the SCP, DCP and the deeper layers. This is a patient with BRVO, and this is a patient with CNVM. I don't know if you can appreciate there where you can actually see how deep the membrane is, much below the vasculature. So this is fantastic. I mean, you don't really need to, even an OCT sometimes in these particular patients, if you see the top left image there. So to conclude, when a clinical examination is paramount, OCT does add to it in terms of confirmation of the diagnosis. You can classify more accurately, you can plan your intervention, you can monitor treatment and progression, the prognosis, and it's a highly educative tool to the patient. They understand, and the next time they come, they'll say, even they actually read the image before coming to the clinic, they'll say, ma'am, 20 microns kam hua hai, which is probably not really important enough. We were looking more for 200 microns, but still they're happy. Okay, and when they come in saying 50 microns bada hai, it's more easy for you to tell that patient probably requires treatment. So it's definitely helpful. Octa, yes, it has multiple advantages. This is what I want you all to definitely try to read up on the biomarkers. It's extremely useful when you want to prognosticate and plan. Other less common pathologies like trauma I haven't really covered. Quantification both on OCT and octa, and then manual segmentation you have to learn. You have to go and sit at the machine and do it. It's impossible for you all to teach you. Thank you so much. I'm sorry overshot by a couple of minutes.
Thank you so much, ma'am. That was a very in-depth and detailed presentation. Do you have any doubts for ma'am?
Any questions?
Yeah. Yeah. Come to the front, come to the mic and speak, please.
Go back. That was the last one, no? This one? OCT, right? Yeah, this one? What do you want? Yeah, this is MACTEL.
Any other doubts? Okay, thank you. I think the next talk, I would like to invite my senior, Dr. Tirumalesh. Dr. Tirumalesh is a consultant in Vitreoretinal Services in Narayan Netralia. His area of interest include MIVS, macular hole RD and TRD, and he is also interested in the artificial intelligence. He is heading it in NN. Over to you, sir.
Okay, thank you very much, Obli. And the topic that was given to me was landmark clinical trials in Retina that one should know. Whenever it comes to clinical trials, it means that you have to remember a lot of things. But these are facts. These are facts based on which we treat. These are facts based on which we counsel the patient and take decisions. So I have kind of divided them into these 4 topics. We'll be discussing AMD, DR, RVO, and endophthalmitis, because this covers the majority of the clinical trials that one should keep in mind when we talk about medical retina. So now age-related macular degeneration, we all know what this is. So you can see that there are a few drusen's. In the other slide, you see that there is a membrane, there is blood, lipid, and fluid. So we know that the left end of the slide is neovascular AMD, the right end of the slide is non-neovascular AMD. So which is the non-neovascular AMD that one should treat and which one should observe? So the early part of the AMD is, when you go back to this slide, you see there are multiple small drusen's in the periphery there. If only those are there and you don't have larger drusen's, then you tend to observe that patient. That is called as early. So once you have what is called as drusen's, which are between 63 to 124 microns, they appear softer, they appear to be more confluent. If that is there, then that is your patient that you start treating. If definitely there is a drusen which is more than 125 microns, where you can see a large drusen like that, that means again that is a patient that you would want to treat. And along with that, if you see a geographic atrophy like this, that's another patient that you want to initiate treatment. If these are not there, then these patients we do not treat. Now, when we have these patients, who said that we should be treating is this particular report, the ERG report number 8, was the one which said that if you have a patient who's older than 55 and who has at least one large drusen, or if he has a non-centric geographic atrophy, or if he has intermediate sized drusen in both the eyes, or if he has large drusen in one eye and presence of severe AMD in the other eye, these are the patients that we should be considering treatment. So how do we treat these patients? Is we give zinc and supplements. So they have also classified the patients into category 1 to 4 depending upon the size of the drusen and presence of pigmentary anomalies. Now what did the study tell us was that we should start these patients on zinc supplement, which is about 80 milligrams. And to prevent zinc-related anemia, we add 2 milligram of copper. Along with that, the ERG1 report said that we should be using 50 milligram of beta carotene and vitamin C. So when you're prescribing the drug, you should remember that you should make sure that these are the ingredients which are there in it. What did this particular combination do was that it reduced the risk of progression into more advanced cases in about 25% of cases, and 90% risk reduction for severe moderate visual loss of more than 3 lines in 5 years. The study also defined intermediate stage AMD as one large drusen of more than 125 microns. Now, this is the risk reduction once you start treatment. It's that if you know a patient who has been in category 3 or 4 and you start giving oral supplements, the risk reduction the risk of them developing advanced AMD is about 50% in 5 years. And by 10 years, it is about 67%. So when you give the supplements, you reduce the risk by 33%. It's not that you give the supplements and those patients are not going to develop severe AMD. Only about 33% of the patients, despite starting oral supplements, are going to have severe AMD. Now, the problem with ERG1 formulation was that people had smoking history. That was one of the strong risk factors for development of AMD, and people who had smoking with beta carotene tend to develop lung cancer. So to prevent that, ERG2 was designed where instead of beta carotene, they were started on lutein and zeaxanthin, 2 and 10 mg, and the rest of the preparation remained the same. So with that, it showed similar kind of risk reduction as you saw in ERG1 report. Now, with reference to neovascular AMD, now the newer terminology is we don't call it as CNVM, we now call it as macular neovascularization. So the macular neovascularization, if it is present, then it shifts the AMD from a non-neovascular to neovascular. The clinical signs of neovascular, or if you look at the fundus, is that if there is presence of blood, lipid, or fluid, and the patient is more than 50 years old, then it is AMD until proved otherwise. If you do a OCT, like what Dr. Chaitra showed, you can find a membrane, you can find fluid. So it is the fluid and the membrane that we are trying to treat. Now, with reference to treatment evolution and which trials that one should probably look into is that before the onset of laser, people used to observe. Once the laser came, they thought, okay, let's burn the membrane and see what happens. And what they found was that, once they burned the membrane which was there in the center, the results were worse. That's why the MPS study gave only one rememberable point, which is that if the membrane is extrafoveal, which is beyond 350 microns from the center of the fovea, that you can probably laser. But otherwise, you tend to use other agents. So what are the other agents that are used? The next one is the cold laser, which is called as PDT. So here you use a photosensitizing drug, which is vortiporfin, you inject, which will accumulate in the area where there are leaky vessels, and then you activate it with a cold laser that will cause thrombosis of the membrane. The problem with PDT is that it accumulated in the whole of the membrane and produced a scar which was large. So what it did was it said that compared to observation or compared to the previous one, the vision did not improve, it kind of stabilized at that level. What changed the game was anti-VEGFs. It not only stabilized, it not only prevented vision loss, but it started giving more and more. So more of that is what we would see. So the MPS was based on this purview that you do a fluorescein, you find where the leakage is, and based on the leakage pattern, you classify them as classical. If it is more than 50% of the lesion complex leaking, if it is 1 to 49% of the lesion being hyper, you call them as minimally classic, and if it is less than 49%, you call it as occult. Now, why is this important is that the occults of the previous era are the PCVs of today, right? So now the OCTA has made it more easier. If you have a type 1 where the lesion is predominantly subretinal, that is what was the occult of the previous generation. Type 2 was more classical. Type 3 is the RAP where the neovascularization starts from the retina and then goes down. Now, I think the laser part I've stressed upon, the PTT also I think I've spoken about. Now, with reference to the anti-VEGF agents, these are the currently available ones, but before this we also have pegapatinib, which is an aptamer. That was the first anti-VEGF to get approval. So what happened with pegapatinib was it was specifically blocking the VEGF-A 165 isoform. What it did was it was very comparable to PDT, but it did not give much of visual gain. It is these two trials, which is the Marina and the Anchor, which introduced ranibizumab, which is a pan-VEGF blocker. This kind of blocks VEGF-A and all its isoforms. So what it does is, then they observed that in 95% of the patients who were on this particular anti-VEGF agent, the severe vision loss did not happen. Over and above that, about 62% of the patients had additional visual gain of more than 15 letters. So this kind of changed the game in AMD. Till then they were talking about that we will stabilize vision, but the moment ranibizumab came into picture, they started telling people that okay, you can actually improve vision if you start giving treatment. So then the problem with this was that you have to give treatment once every month. So then they started saying that can we reduce the burden of treatment by reducing it. So what happened the next was what is called as the PIRE trial, where they gave 3 doses of ranibizumab, and then they said, okay, we will give once every 3 months. So what the results of the PIRE behaved was that Anchor and Marina, there was presence of visual gain of about 8 to 11 letters, but in the PIRE it did increase in the first 3 months, but it started following. So it followed a trend just like the Votipofen or the PDT and the pegapatinib group. So by this level, I think we've established that monthly ranibizumab treatment is the only one which will give you vision. So that is one to be pursued. Now the problem is to reduce burden. We did a 3-monthly ranibizumab. It did not work out. So then they introduced what is called as the treat and extend regimen. So what is a treat and extend regimen is the philosophy of treating CNVM is that you give an injection. So in the intensive phase, so you keep giving it monthly till the exudation goes away. Once the exudation is gone, you extend the duration of treatment by 2 weeks. See what happens. If the patient is tolerating the 2-week extension, extend up to 2 months. In the same way up to 8 weeks. But at 8 weeks, you definitely give the injection. So why this 8 weeks was decided for ranibizumab was because the fluid-free interval that ranibizumab was able to achieve was only 8 weeks. And if you are using aflibercept, and that kind of can take it up to 3 months. Now aflibercept, how is it different is, this is a fusional protein. It has, it can both bind to VEGF-R1 and R2. And the trial which established that aflibercept can be used was the VIEW-1 and VIEW-2. It was called as VEGF trap in those days. Now it is marketed as aflibercept, Eylea or aflibercept in the market. Both trials proved that it is non-inferior to ranibizumab. Not just it is non-inferior, but in cases where there was severe edema or edema was more, aflibercept kind of worked a little better than ranibizumab. The second thing that that they also tried to do was, in the initial part, that instead of monthly injection, can we give bi-monthly? So after 3 loading doses, they shifted the dosage from 1 monthly to bi-monthly and saw whether does it do any difference. But in the initial part, they were not able to do it. But once the treat and extend regimen started functioning, it tended to give more and more benefit. Now, where does it leave bevacizumab? Bevacizumab was one of the first anti-VEGF which was tried. It is a full-length antibody, although the FDA did not approve its use for usage in the eye, but it was very well approved as a drug in systemic cancer, but it is used as an off-label drug. The CAT and the IVAN trials actually showed that, if you compare monthly bevacizumab with monthly ranibizumab, the difference was not much. So it is as effective, but it also showed that if you are comparing it with aflibercept tends to do a little better than both ranibizumab and bevacizumab. Now this is a new kid on the block, which is brolucizumab. What it does is, this is not a full-length antibody; it is a single-chain variable fragment, so it can be given at a higher dose. This is one drug which has a superior drying effect compared to the other this thing, and this can also be given at 3 monthly intervals, which means that the burden is less. But the problem with brolucizumab was about 4.6% of the patient had intraocular inflammations. So you have to keep a very close watch on it, and this is not largely adapted as the primary drug till now. Till now, the mainstay of treatment still is ranibizumab and aflibercept. Now there's another drug which is coming into the market, which is faricimab. Now faricimab is a little different. This kind of blocks not only the VEGF, but it can also block angiopoietin 2. So it can give a combined blockage. So the talk is now that, if you are using faricimab, the treatment duration can be extended up to 4 months. I think with that we have kind of got the gist of how to treat AMD and what are the drugs that can be used. Let's move on to DR. Now we know DR also is one of where there are enough number of confusions. Initially when the patient comes to you who does not have DR, he has questions that when would I get, how long is the association, what should be the control, does control have any role in prevention, and once I get the disease, how to control it. Now the answers to these questions lies in these kind of studies. The WestDR was one study which followed up the patients and told, what did it tell us is that longer the diabetes, higher the chance of development of DR. If you are a type 1 diabetic, you would probably end up with PDR a little earlier. So if you compare between type 1 and type 2 diabetes, you see that nearly 99% of patients with type 1 diabetes, by the time it was 20 years, they developed DR, and more than 50% of them developed a PDR. And the chance of vision being worse was higher in patients with type 2 diabetes because they tend to have more of proliferative diabetic disease. It also told us that if there is 1 point increase in HbA1c, there is 25 to 40% higher risk of visual loss. So this study not only said that if there is increased duration of diabetes, you are going to develop DR. It also said that if the HbA1c kind of increases, it will also cause the problem. To verify these effects, they did the DCCT to check, does it have a role? Should we do a very strict control? Now the answer to both the control study is that you have to keep the diabetes under very strict control. So the question is, what do you mean by very strict control? So it should be less than 7. So that is the baseline benchmark. So intensive therapy definitely delays the onset and also slows the progression of not only diabetic retinopathy, it also prevents macro and microvascular complications. Now the UK PDS did the same thing with type 2. This also says the same thing, that you have to keep the diabetes under control. In addition, type 2 are the patients who also have hypertension. So if the hypertension is there, it adds a insult to injury kind of a scenario. So do not only keep the diabetes under control, but also keep hypertension under control. It is very important. And the third one is also tell the patients that smoking is bad, please don't do it. And third part is keep the cholesterol part under control. So it means that whatever systemic associations are associated with any metabolic disorder should be controlled. The next thing that was kind of worrying us was that when severe diabetes is there and patients develop vitreous hemorrhage, what is the time to do the surgery? So conventionally, people used to operate between 6 months to 1 year in those days in 90s because vitrectomy machines were not all that great. So they were randomized in the DRVS to check if early vitrectomy gave any benefit. So when they say early vitrectomy, they mean that a vitrectomy within 1 month, and the conventional is between 6 months to 1 year. So what it said was, if it is a type 1 diabetic and the patient has a vitreous hemorrhage, it is always better to do a surgery. If it is type 2, kind of do a PRP and then kind of consider. The conclusion are in severe vitreous hemorrhage causing significant reduction. If it is a type 1, kind of take the patient for surgery up. Now to look at early treatment. When they say early treatment, they were looking at, can we do it in severe NPDR phase, even before the proliferation sets in? Can we do it in moderate? Say if patient comes in moderate, if I do a PRP, can I prevent PDR? So that was one. Second thing is, the patients were using aspirin. If the usage of aspirin, does it cause more hemorrhage? If there is macular edema, do I treat? So the ETDRS kind of coined multiple terminologies. It helps us in kind of classifying a disease a little more better than the previous classification. It classified at mild, moderate, severe. If you have only microaneurysms and it's mild, if you are associated with a few hemorrhages in less than one quadrant or 1 or 2 quadrant, it is moderate. It is severe once there is 4 quadrant hemorrhage, or if there is 2 quadrant venous looping or 1 irma. And if there is proliferation, then you classify it as proliferation. So this particular classification was given by the ETDRS. It helped in the follow-up protocols of it. It also helped us define what is macular edema. Many times if there was a hard X-ray, it was considered to be a macular edema that initially caused confusion. What they clearly said was, to say edema, there should be fluids. How do you identify that? There should be retinal whitening. Where should be the retinal whitening? It should be there in the central 500 microns. If it is adjacent in the central 500 microns, but if there is a presence of hard X-ray anywhere within the central, that was called as CSDME. Or if there is large area which is abutting to the center, that was also called as clinically significant macular edema. So this kind of gave an idea of what should be treated and when it should be treated. Now to kind of simplify it a little less, and with available of OCT, we now talk about whether the edema is centrally involving or non-centrally involving. Majority of the times we tend to treat the centrally involving ones. So what the ETDRS told in those days was, if the patient is having moderate or less than severe, don't do PRP because it is not going to give any benefit. The second thing that it said was, you can consider doing PRP in severe NPDR in exceptional scenarios. Patient is not been, cannot come for follow-up, or is one-eyed and he has a severe NPDR. In those kind of scenarios, you can probably do a PRP even in severe NPDR. But what it said was, the benefit that it is going to give the patient is when the PDR is associated with HRC. HRC means if there is presence of any pre-retinal bleeding, or if the NVD is more than half disc area. It also said that if there is a focal edema, you do a focal laser. If there is a diffuse edema, you can do a grid laser. But whatever said and done, till the ETDRS days, before the introduction of VEGFs, we were talking about maintaining the visual acuity. We never spoke about improving the visual acuity. So what changed the scenario was introduction of anti-VEGF. We tend to take a lot of drugs that worked in AMD, and we tend to use it in other scenarios. These are the 3 trials which kind of establish the role of ranibizumab as the drug of choice whenever there is a patient who comes with diabetic macular edema. The resolve, the restore, rise and write. And aflibercept's role was established by Vista, Vivid and Da Vinci trial. So what it did was, the patients were kind of randomized between ranibizumab and the sham group, and they said that, whenever you use ranibizumab, more than 60% of the patient had more than 10 letters of visual gain. Again, here they were giving monthly ranibizumab injections. The other trial which kind of gave the same results was the rise and write, where now we do not talk that laser is the primary modality of treatment. If there is any chance that what is the drug of choice for diabetic macular edema, it is ranibizumab without a doubt. Now to further study how long should we give prompt laser, should we do deferred laser, can it be used in PDR? The drcr.net kind of answered this question. It also looked into whether can we go back to the protocol where we are doing photocoagulation, and whether we are going to give steroids, and does it have a role. The protocol B kind of evaluated this. It said that if you still want to do laser, you can do focal and grid laser, but IVTA initially will increase the visual acuity, but it can cause glaucoma, it can also cause cataract. Once you do a cataract surgery in DR, it is going to go haywire. So laser was superior in the protocol B compared to IVTA. What happened next was they compared the superior one, which was laser, with ranibizumab. They also kind of evaluated ranibizumab with prompt and ranibizumab with deferred laser. What protocol I said was that you can use ranibizumab with either a prompt or a deferred laser, and it was far superior than laser alone. The second thing that it also said was, if you are going to do deferred laser, that is going to be better than doing prompt laser, because in the prompt laser group, the number of letters that gained was a little less. Now, the evaluation of whether I can give ranibizumab for proliferative diabetic retinopathy was answered by protocol S. What protocol S said was, if you give intravitreal ranibizumab, it is better than doing laser, because the adverse events that were seen when we gave ranibizumab intravitreal was far superior than PRP. Now, the protocol T kind of evaluated that, with the availability of aflibercept, was aflibercept superior. So at 2 years, what they found was, if the vision was 20/50 at the inclusion time, all of them fared relatively same. But if you included the patient with a severe vision loss, where it was 6/60 or worse, those kind of patients did a little better with aflibercept. But comparatively, all of them were very similar if you included with the patients with only moderate visual loss of up to 6/18. I think we have kind of touched on most of these. Let's go to BRVO. I do have time, right? So similar kind of questions were there, which BRVO to treat, whether we should do laser photocoagulation in these patients. If you're doing laser, is grid laser better, or So the BVOS study said that peripheral argon laser photocoagulation can be done to prevent vitreous hemorrhage if the patient is having neovascularization. It also said that don't do PRP the moment you see a BRVO. See if the patient develops a neovascularization. Once the neovascularization is there, do a laser. Second thing it also said was, if the patient is having BRVO, developed macular edema, if that macular edema is causing vision loss of 6/18 or worse, treat that patient with a macular grid. These were the days where anti-VEGF was not available. So after that, what happened was, the similar study was done in CVOS as well. The conclusions were very similar. If there is a CRVO patient, you have to examine the patient once every month. Why? Because these patients tend to develop an NVAE or an NVG. So some people said, okay, can we do laser before, instead of doing a 1 monthly follow-up? The answer is no. You wait till there is an NVA or an NVA, and only then you do the laser. The second question that the study was trying to answer was, if you have a CRVO with macular edema, can I do macular grid just like I did in BVOS? The answer is no. Why? Because the angiography tend to become better, but the vision wise it did not do any better. So macular grid is a strict no-no if you are dealing with a patient of CRVO. Now let's look at what happens if we use the drugs which were successful in AMD and DR in patients who are having vein occlusion. Now the Bravo study in 2008 kind of included patients of up to 400, and they were randomized to both ranibizumab and sham. And they found that if you use monthly ranibizumab, it tends to give about 15 letters improvement, which was far superior than doing a grid laser in the BRVO with macular edema. The CRUE study kind of established similar kind of facts when it comes to central retinal vein occlusion with macular edema, because central retinal CRVO with macular edema did not have any treatment at that point of time. When compared to that, it definitely showed that it has a better role. Now the Geneva trial kind of evaluated another important drug, which was the dexamethasone implant. So the improvement was greatest with dexamethasone implant at 60 days. So there were two dexamethasone implants which were kind of evaluated. One was a 350 microgram and other was a 700 microgram. So what it showed was, if you use 750 microgram, you can actually delay the treatment for up to 3 months. But the greatest improvement was seen at 60 days, which is at 2 months. Now let's look into the last part of my presentation, which is the end of vitrectomy study. So if the patient has end of, when to treat, and what did the study tell us? So this was an investigator initiated trial. They included 420 patients who had post-cataract surgery end off. So the study said that if within 6 weeks of surgery, if the patient had end off, then we would say that it is procedural related. So they diagnosed end off based on presence of AC reaction, hypopyon, or obscuration of the details by vitreous opacities. Any corneal problems they excluded, and any patient who came with hand motions or poor vision was either randomized to doing a vitrectomy or doing a tap and inject. So the main outcome measures was visual acuity in the long run by up to 9 months, and media clarity. So the results was, there was no difference in the final visual acuity or media clarity with or without use of systemic antibiotics. So if you are having an end off and you think that I will give ciprofloxacin and probably get away with it, it's not going to work. Second thing is, in patients who are having vision which was hand motions or better, there the tap and inject did as good as vitrectomy. If the patient has worse vision than that, then the vitrectomy produced a 3-fold increase of the patient getting better. But one should remember that these studies were done in the era where the vitreous cutters were not as good. Currently, we tend to err on the side of doing vitrectomy a little earlier. But nonetheless, this is a broad guideline which tends to prevent an unnecessary surgery that might be done in an eye which has a very high risk of losing vision if you are very aggressive in your treatment. Yeah, thank you so much. If there are any questions, you can.
Thank you. That was a very in-depth presentation. Do you have any doubts? If there is no doubts, then we can go on to the next presentation. Next, I would like to call Dr. Piyush Bansal. Dr. Piyush Bansal is one of the renowned vitreoretinal surgeons and an instrumental force in Bansal Vision Institute, Pune. He is going to talk about FFI ICG, autofluorescence.
Okay, I need a... Unbolt.
Usually Pongal makes me feel like a baby.
A very good morning, everyone. Thanks, Dr. Abuli. So meanwhile, while this connects, I'll be speaking on fundus fluorescein angiography, ICG, and indocyanine green angiography, and fundus autofluorescence. Now, like we all know, OCT has in So OCT and OCTA has pretty much changed the way we treat and diagnose many retinal conditions. However, these investigations, understanding them is very important. Your understanding of the disease processes is validated. It increases with this, as well as overall understanding of retinal diseases also is much better when you have a good understanding of these investigations. So it's a very vast topic, so going through everything in detail is going to be difficult, so I'm going to be rushing through most of the things over here. So fundus fluorescein angiography, to begin with, it refers to photographing fluorescein dye in the retinal vasculature following an intravenous injection of fluorescein sodium. The evolution has been long going. It's been, the most important point over here was that it was two medical students, Novotny and Alvis, in the 1950s, who essentially developed the principles of fluorescein angiography. Now, sodium fluorescein is essentially plasma brown, and 80% of it is protein bound, and it rapidly diffuses into extracellular spaces. The normal adult dose over here is 500 milligrams, and it is usually given as 5 ml of 10% or more commonly as 3 ml of 25% sodium fluorescein as a bolus in the antecubital or another vein. The elimination is essentially through the kidneys, and complete elimination occurs through the urine in 24 hours. So it's important to tell the patient that the color of the urine will change, and in the first 24 hours itself, the dye will be evacuated. Contraindications include pregnancy and hypersensitivity to the dye. Now, side effects are a few. The important ones over here and complications would be extravasation of the dye into local tissue, into the skin, can cause local tissue necrosis. Nausea, emesis, vasovagal reaction can primarily occur due to the procedure itself, not due to the dye. Thrombophlebitis can happen, and there can be allergic reaction. So it's important to have the emergency medicines ready when you're doing fluorescein angiography. Now, the important thing to know over here is luminescence. Now, what happens is, this is the basic principle: when there is an emission of light from any source other than high temperature, you have luminescence. Light energy, when it hits a luminescent material, there are free electrons that are elevated into high energy states, and gradually there's a decay of this into lower energy states, which causes luminescence. And fluorescence is essentially luminescence that is maintained by continuous excitation. So over here, what happens is, when blue light enters the eye and hits sodium fluorescein, it excites it. Blue light through the excitation filter, it hits the sodium fluorescein, which excites it to a higher energy level, and then that subsequently releases a longer wavelength, that is 522 nanometers, the green-yellow light, which is then allowed to come in back into the fundus camera through the barrier filter. And that is how the recordings are made. So the instrumentation over here essentially is our digital cameras, which could capture 30 degrees, 50 degrees, or 150 degrees view of the fundus. Most of the fundus cameras now have the filters inbuilt, so you just have to hit the fluorescein angiography button, and automatically the barrier filters and the excitation filters are hit. The equipment is a scalpane set, syringes, fluorescein sodium, and tourniquets. Now it's important to obtain consent, make sure that the last meal has been had a couple of hours before, pupil is adequately dilated, and the position of the patient is secured. Now the injection is generally given rapidly. The reason is if it's given over 3 to 4 seconds or 4 to 6 seconds, there's a better contrast. However, this also causes more nausea to the patient. Photographs are clicked every 1 or 2 seconds, and first the primary eye where the pathology is to be captured, that is captured the disc macula, 6 to 8 photos, and then moving on to the secondary eye. Then going on to the rest of the quadrants. Besides a color photograph, you also want to get red-free photographs, control photographs. Now, you can go through the anatomical considerations over here. It's important to know the blood supply to the disc and also the concept of blood retinal barriers, the inner and outer blood retinal barriers. It's important to look at the macula, and knowing that the macula generally would hypofluorescence because of the absence of capillaries in the foveal avascular zone, the melanin and the xanthophyll. Now this area would constitute roughly around 400 to 500 microns in diameter. Once you know what the arm retina time is, it's essentially the time interval between the injection of fluorescein into the cubital vein and the appearance of fluorescein in the retinal vessels. Normally this would be around 8 to 15 seconds. In certain conditions like ocular ischemic syndrome, this would be delayed. Now one should know the phases of angiogram, which are the choroidal phase, the arterial phase, the arteriovenous phase, the venous phase, which further has the early, mid and late phase, the recirculation phase and the late phase. The choroidal phase essentially shows early choroidal fluorescence, as you can see over here. If there is a coeloretinal artery, it also shows up in this particular phase. Next would be the arterial phase, which starts to show up within the first 1 to 3 seconds after choroidal fluorescence, or up to around 10 seconds or 15 seconds after the injection, depending on where the dye is injected, whether it's in the, at the wrist or it's in the antecubital vein. The next would be the arteriovenous phase, where there is a filling of arterioles. This occurs 14 to 16 seconds after dye injection. The veins might show an early laminar flow in this phase. Next we have the venous phase. There's an increasing fluorescence of the veins, as you can see over here, and a decreasing fluorescence of the arteries. Now this is a very good time to look at the foveal avascular zone. Then there is the recirculation phase, which occurs about 2 to 4 minutes after the injection. And the veins and the arteries show roughly around equal fluorescence in this particular phase. And then you have the late phase, which typically comes in after 7 minutes of the injection. And you can have late staining of the optic disc, which is again normal in this particular phase. So understanding the FA is important to understand the relationship between time and the area. You have to look for these things, change that happens at one particular place over a period of time, changes that happen to multiple places at a given point of time, and also to know, what one is looking for and when to look for. So the types of abnormal fluorescence essentially would be hypo and hyperfluorescence. Hyperfluorescence is essentially a reduction or the absence of normal fluorescence, which could be either blocked or due to a vascular filling defect. And to differentiate between the fluorescence from a vascular filling defect and blocked fluorescence, one also needs to correlate the hyperfluorescence on fluorescein angiogram with the retinal picture. So what you see on some of the subsequent slides is a schematic diagram on the left with a picture on the right, and what you see is hemorrhages at different levels, which could be subhyaloid or intraretinal or sub-ILM, as you can see over here in the color fundus photograph. And similarly, correspondingly, you see a blocked fluorescence on the angiogram. Similarly, in this case with the central retinal vein occlusion, you can see blocked fluorescences on the angiogram, which correspond to the hemorrhages present seen on the fundus photo. Another patient where, so what you see over here is in the color photo, you see a subretinal hemorrhage over here along with the yellowish nodule over here very close to the artery. And when you do an angio for this particular patient, you see corresponding hypofluorescence, which is due to a blocked fluorescence because of the subretinal hemorrhage. And in subsequent frames, you see that the hypofluorescence is maintained along with an increasing intensity of fluorescence at this level. So one important thing over here is, more importantly, rather than jumping into the diagnosis, most of the times when you're given an angiogram to read in the exams, one should perhaps analyze the angiogram, starting with which eye it is, describing the optic nerve head of the optic disc, the macula, any particular areas of hyperfluorescence, any particular areas of hypofluorescence. You must also describe the arteriovenous ratio or any other abnormalities that you would not particularly see in normal angiogram. So another case where you can see subsequent arterial phases, arteriovenous phases, and over here what you can see is some amount of hypofluorescence because of less perfusion of the vessels over here. You have capillary dropout areas. You have some areas of hyperfluorescence also showing up, which I'll come to in the later slides. Now, in this particular case, you see some amount of clouding of the retina. And in such a situation, when you do an angio, you see a delayed filling. You can see this, the choroidal vessels filling up. Slightly later, the retinal vasculature is still not filled up, and then you have some amount of hypofluorescence in the vessels itself, in the retinal vessels. So again, this is, you see a patchy filling of the retinal arteries and the veins. So this hypofluorescence is essentially because of a vascular defect, again leading to a CRAO. Now this is a particular patient of a central retinal vein occlusion. You can see multiple areas of hemorrhages all over the retina, tortuous blood vessels. And when you do an angio in this particular case, you can see early areas of blocked hypofluorescence. Gradually, when you move on to the arteriovenous phase, you see certain areas of are being highlighted where there's hypofluorescence because of capillary dropouts. The macula appears to be hyperfluorescent because of leakage of fluid. And the capillary non-perfusion areas, the hyperfluorescence, this is being highlighted better in the later phases. Further, you have some amount of hyperfluorescence adjoining the vessels. So coming to hyperfluorescence, this could be essentially because of either a pre-injection fluorescence because of autofluorescence or pseudofluorescence. It could also be because of vascular abnormalities or leakage. So again, hyperfluorescence would be because of either leakage or staining or pooling. It's important to know these different terminologies and examples of these particular situations. It's a good idea to take a control photograph of the fundus before you actually start the fluorescein, because initially you would have a dark photograph which is hyperfluorescent. In case if it's not dark, you can, it's probably due to an autofluorescence or pseudofluorescence. Autofluorescence being because of conditions like optic nerve drusen, astrocytic hematomas, lipofuscin. Whereas transmitted fluorescence would be essentially because of a window defect, because of a defect in the pigment epithelium. There are many conditions that show up with a hyperfluorescence window defect. You can go through them in your text. Now, this is when you have a patient with age-related macular degeneration, especially the dry one. You can see that there's some amount of autofluorescence because of the drusen. You also see a blister kind of an appearance over here, which could be because of a pigment epithelial detachment. And when you do an angio, you see that in the earlier stages itself, it shows up as a hyperfluorescence, as a transmission defect. And then as you progress in the further stages, in the arteriovenous phase, in the late stage, the size and the size generally stays the same. You might have a slight increase in intensity, or generally the intensity would remain the same. Hyperfluorescence could be because of anomalous vessels also within the choroid or the retina or the optic nerve head. Now what you see over here is a yellowish membrane at the macula, which perhaps brings you to a differential diagnosis of a choroidal neovascular membrane. Now when you do an angiography in such a situation, you can see that the early arterial phase itself, you have some amount of hyperfluorescence at the macula. It's a kind of a lacy pattern over here, and then gradually in the arteriovenous phase, it becomes more obvious. The hyperfluorescence at the macula becomes more obvious. And then gradually in the later stage, there is a leakage from that particular area because of the leakage that is happening from the choroidal neovascular membrane. So the diagnosis would be essentially confirmed. Another similar patient where you see a membrane in the macula with the surrounding intraretinal hemorrhage. In the early phase itself, you see this lacy pattern, which is nicely demonstrated over here, which shows hyperfluorescence. And now this is typically a classical choroidal neovascular membrane. And the earlier onset of the earlier hyperfluorescence essentially shows the connection with the choroid. Now, gradually, when you keep moving on to the later phases, the hyperfluorescence and the intensity of hyperfluorescence increases. And in the later phase, you have leakage, as I showed you in the previous picture as well. Now, in vascular conditions like diabetic patient, diabetic retinopathy, when you have an NPDR, a non-proliferative diabetic retinopathy, what you see over here is hemorrhages. So I have a long slide, so a long presentation, so please tell me if I'm overshooting my time. So in case of this particular patient, you see intraretinal hemorrhages as well as some thickening at the macula. Now, when you do an angio for such a patient, you see hyperfluorescence because of these microaneurysms which are lightening up. You also note that the foveal avascular zone is distorted instead of the smooth rounded edges that it usually would have. And you have areas of hypofluorescence because of capillary dropouts as well. In the later phases, leakage from microaneurysms can also be seen. So leaky microaneurysms can be picked up in the later phases in such situations. A patient with coats where you see peripheral exudation. So when you do an angio in such a situation, you can make out the hyperfluorescence from the telangiectatic vessels in the periphery, and you see hypofluorescence because of the retinal ischemia in the periphery, and you see capillary dropout areas. Gradually, when you go on to the later stages, you see an increased hyperfluorescence and due to the abnormal telangiectatic vessels. Now, in patients with PDR, again, what you see over here is retinal thickening, and macular thickening, exudation, hemorrhages, etc. And when you do an angio in such a situation, in the early stage itself, you see some amount of hyperfluorescence of the macula. You see multiple areas of blocked fluorescence in the paramacularly, as well as some amount of staining, which starts pretty early around the patient, around the laser scars. Essentially, again, in situations where there is a doubt whether there is neovascularization at the disc or elsewhere, fluorescein angiography would be useful, as in this particular case, you see that there is a hyperfluorescence nasal to the disc. And in the later stages in the arteriovenous phase, the hyperfluorescence picks up. There is an increased intensity over here. The other areas also show reduced hyperfluorescence, hypofluorescence. So that is essentially because of the capillary non-perfusion. And in the later stage, you see the intensity of the hyperfluorescence because of the neovascularization has increased. So this would definitely be a proliferative diabetic retinopathy. So leakage is another reason for hyperfluorescence, where this can happen if it's in a preformed space, you call it pooling, and if it's into the tissue, it's called staining. So this is a schematic diagram which shows sensory retinal detachment over here. There's a break into the pigment epithelium, and because of this, the fluorescein moves through through this break and then into the subretinal space. As you can see over here, it's not very obvious, but there is a yellowish lesion over here. And when you do an angio, there's hyperfluorescence, which has a very defined size. It does not, the margins are very clear. There's no fuzzy margin. The margins remains the same, whereas, and the size remains the same, and the intensity remains the same. So again, this is essentially a pigment epithelial defect. You see serious elevation at the macula over here, and when you do an angio, you see a pinpoint leakage in the earlier stage, and then gradually when you keep moving ahead, you see that there is an increase in hyperfluorescence, not just in this particular area, but the adjoining areas as well. And in this particular area, what is typical is you see a rising level of fluorescein, and then gradually it starts to envelope that sensory detachment area like a smokestack. So you have this typical description of a smokestack appearance in CSCR. Another similar patient with an elevation and some exudation, and when you do an angio over here, you see a pinpoint hyperfluorescence. So this is essential to make out that hyperfluorescence area in the early stages, because in case if you want to treat such patients, it's important to identify the exact location. And you see the increasing intensity of hyperfluorescence because of that leaking point. So another similar patient where you have a large area of a serous detachment over here on the fundus photo, and then you have a similar area of hyperfluorescence on the angio, and then gradually you see the hyperfluorescence increasing and enveloping the area of serous detachment, as you can see over here in the later stages. So what this shows is this diagram shows us large cystic spaces, and these have a very typical configuration of showing up as hyperfluorescence as well, especially in patients with the macular edema and diabetic retinopathy. So cystoid edema again has a very different configuration. You see that the configuration is different over here as compared to the second picture. So you have a patelloid appearance when the edema is essentially at the fovea, and when it's parafovea, when it's non-center involving, it will be a honeycomb sort of an appearance. In patients with vasculitis, you might have active vasculitis, you might have hyperfluorescence adjoining the inflamed retinal vasculature, as you can see over here. Now, staining essentially, like I said, is leakage of fluorescein into the tissue or material, as compared to pooling, which is into an anatomic space. So over here you see hyperfluorescence due to staining of the CNVM scar. Healing choroiditis also would give a similar picture, where you have a staining of the choroidal scars. VKHS syndrome, where you would find early pinpoint hyperfluorescence, and then gradually you see leakage into the areas of subretinal fluid, detachments. Now, white dot syndromes, you would essentially have hyperfluorescence right from the beginning, and then gradually the intensity of those areas tend to increase. Now you see this yellowish lesion over here, which should raise suspicion of a choroidal hemangioma. So again, these tumors would light up pretty early. You can see that there is hyperfluorescence in the beginning itself in the choroidal phase, and then gradually the intensity of the hyperfluorescence increases. You see the retinal circulation also being highlighted over there. It's kind of like a double circulation. Now, wide field angiography is also important. Why now? Because we can, instead of taking multiple montage pictures or multiple quadrant photos, in a single photograph you can pretty much visualize the retinal periphery and pick up leakages or capillary non-perfusion areas or any other abnormalities in such situations. So moving on to endocyanine green angiography as compared to sodium fluorescein angiography, over here you are essentially looking at the choroid. The dye over here is tricarbocyanine dye, which is highly protein bound as compared to sodium fluorescein. The molecular weight is more as compared to sodium fluorescein. Now this absorbs light at 805 nanometers and then fluoresces around 835 nanometers. The indications over here are plenty, but the most important ones are exudative AMD, idiopathic polypoidal choroidal vasculopathy. So PCV, it's actually still the gold standard, differentiating retinomatous angiomatous retinal angiomatous proliferation from PCVs. Central CSCRs, again differentiating it from PCVs. Choroidal tumors, white dot syndromes, choroidal atrophy, ocular inflammatory diseases like sympathetic ophthalmia. Now the equipment over here is, could be either similar to the Fundus camera, which sometimes have dual modes. So a digital Fundus camera, or you can use a confocal scanning laser ophthalmoscope, the standard dose being 25 milligrams in 5 ml. Now, relatively less contraindications and complications with ICG angiography. The absolute contraindication over here would be patients allergic to iodine or shellfish, or patients with uremia. Nausea, vomiting, and anaphylaxis can obviously occur, and you must always have your emergency medicines ready. The phases over here would be the early, middle, and late phase. The early phase would be divided into 3 stages. The first stage, which begins pretty early, 2 seconds after the dye injection. It's marked by rapid filling of choroidal arteries and choriocapillaries, and there's an early filling of choroidal veins. The second stage begins 3 to 5 seconds after the injection, and larger choroidal veins and retinal arterioles fill up with the dye. Third stage would be 6 seconds to 3 minutes, where the choroidal watershed zone fills up. You have the middle phase, which goes on from 3 minutes to 15 minutes, and there's a characteristic fading of the retinal and choroidal vessels. And the late phase beyond 15 minutes to an hour, where there's staining of extrachoroidal tissue. Now over here, again, similar to fluorescein angiography, you have hypo or hyper. You have hypofluorescence. You can also call it hyposenescence, or hyperfluorescence, or hypersenescence. Hypo is generally seen when you have blocked fluorescence. So just to make it easier to remember and understand, I'll use fluorescence. So you can have blocked fluorescence, or you can have, because of pigment, hemorrhage, or exudation, you can have vascular filling defects. You can have hyperfluorescence because of either pseudo or transmitted fluorescence, because of RP defects or scleral thinning. Abnormal vessels will cause hyperfluorescence, and a leakage at because of lesions at the optic nerve or vascular. So coming to PCV now, what is PCV? It's essentially an abnormality of choroidal circulation in which there's a vascular network which is formed in the inner choroidal layers. Now, this has an aneurysmal bulge, usually at the margin of this network. Now, this aneurysmal bulge is clinically visible as a reddish-orange polyp-like structure. Now, it's important to know that these polyps typically appear within the first 5 minutes of ICGA and then persist on to the late stage. Now, the Everest trial, which you can go through, again, has laid down criteria of when you can label it as PCV. So essentially, this would be how a polyp would appear. You would see a feeder. There would be a branching vascular network which can be visualized much better on ICG, and then the polyps which would show up on ICG as compared to an angiography. So beginning from the early stage to the later stages, you see hyperfluorescence in the larger choroidal vessels over here. Now, again in PCV as compared to an angio over here, where you see a diffuse leakage, hyperfluorescence, over here in an ICG you would see pinpoint kind of a hyperfluorescence surrounded by an area of hypofluorescence, which would typically be because of a polyp. Now, FA classification of CNVM essentially is between, it's divided into classic and occult, the CNVM membranes. You can go through the differences later. The ICG classification, however, is a little different. You have a focal spot, which is comparatively less, around 29%, where the size of the hyperfluorescence is comparatively smaller. It's less than 1 disc diameter. And a plaque, which is generally which is seen more often. It's a larger hyperfluorescence, more than 1 disc diameter, which could be well-defined or ill-defined. And then there's a combination of both as well.
Piyush, can you summarize maybe some clinical images and close, because we are time now?
Sure. I'm just about to finish, I think. So, again, it's a good modality to differentiate between RAP lesions as well as RAP and polyp. As you can see over here, you can see a lesion over here. And you can, in the angio, you can make out that there's a feeding retinal vessel over here. And similarly, ICG can be useful to differentiate between CSCR and PCV. And when you compare it to the fluorescein angiogram, the areas of leakage show up as hyperpermeable hyperfluorescent areas on the ICG. CNVMs can be picked up better over here. In other ocular inflammatory diseases, you see multiple areas of hyperfluorescence, which with response to treatment, the size generally starts to reduce. Similarly, in sympathetic ophthalmia, in white dot syndromes, you see it's very difficult to sometimes pick them up over angiography, and they show up as hyperfluorescent areas, multiple hyperfluorescent areas on ICG. The treatment response, the size of these hyperfluorescent areas would reduce. Similarly, you see the hyperfluorescence on ICG in APMPP and Burchard chorioretinopathy. So, coming to the last part, the autofluorescence. Now, autofluorescence imaging is essentially the use of naturally occurring fluorescence from the retina to provide an indication of RP health. And this is essentially because of lipofussion, which is cross-linked protein, which are cross-linked protein units. They're non-degradable and they cannot be excreted, so they accumulate in vivo. Now, these so fundus autofluorescence helps in the identification and early detection of a retinal condition, sometimes before the changes actually are picked up by other modalities. And they help in the tracking of changes over a period of time due to lipofuscin accumulation. The principle is that lipofuscin fluoresces when exposed to short wavelength light. So fundus autofluorescence increases when there's RP dysfunction due to impaired processing and clearing of lipofuscin. And the autofluorescence signal may be decreased in the setting when there's a RP or photoreceptor loss. And so a normal fundus autofluorescence would appear something like this, where you have the optic nerve head, which would appear dark because of an absence of RP and thus lipofuscin. The retinal vessels also appear dark because of the absorption by blood. Now, fovea shows a distinct dark area, hypofluorescent, hypoautofluorescent, with a gradual increase in the autofluorescence peripheral to fovea. This is because of the luteal pigments. There are various machines So the uses over here are essentially to look at AMD, Stargardt's disease, retinitis pigmentosa, heredomacular dystrophies, inflammatory diseases. So usually drusen's would show mild hyperautofluorescence due to increased accumulation of lipofusion. And if there's a drusenoid PED, there can be or confluent drusen's, they can cause a pattern of patchy mild hyperautofluorescence. This can prognosticate a further higher risk of development of CNVM at a later date. Now, with advancement of diseases, there are areas of geographic atrophy which develop, which show hypoautofluorescence. Now, these can be studied over a period of time. The progression can be looked at as to the increasing size of the hypoautofluorescence. Now, in CNVM, in a classic CNVM, because of the pre-RP disease, it can destroy and replace the autofluorescence producing tissues, whereas in an occult CNVM, because of the constant irritation of the sub-RP tissue, this can cause increased fundus autofluorescence signals. So it can be used to differentiate between them as well. The active edge of disciform stars can be picked up more easily. In chronic CSCRs, the areas of RP atrophy show up as hypoautofluorescence, whereas precipitates, where you have subretinal precipitates, those areas are going to show up as hyper. And the borders of the descending tracks, you have these descending tracks, the borders also show up as hyperautofluorescence. In Stargardt's disease, you might have areas of hyperautofluorescence. In the periphery, the flecks that are seen, as well as the fovea shows up as hypoautofluorescence surrounded by hyper. The vitelliform material in Best disease also shows up as hyperautofluorescence. So essentially, autofluorescence tells us about the vitality of the RP. It's a non-invasive tool and helps us in planning and understanding the disease better. Thank you.
Thank you. That was a very in-depth presentation. Do you have any doubts? If not, I think we can go for the next talk. The next talk will be given by Dr. Simar Rajan Singh. Dr. Simar Rajan Singh is a consultant, a vitreoretinal specialist in PJME at Chandigarh. He has a keen interest in pediatric retina. Over to you, Dr. Simar.
Thank you so much, and thanks to Dr. Honavar and the team CFS for this opportunity. So just to start off, just a show of hands, how many of you have access to electrophysiology at your hospital or the institute where you work at? ERG, EOG, VEP, anything of those? So about less than 10%. So let's just try and see what these tests can do for us, and I'll try to keep it very basic. All you have to do is try and understand why these tests are important and what is the origin of these signals that we are getting from these tests. So why electrophysiology? It is the only objective assessment that you can get of vision for a person by any of the tests. Rest everything is subjective to interpretation, subjective to what the patient is saying. It's very subjective. This is the only objective test which gives you the functionality of the entire visual pathway. You can get the anatomy from many other tests, but the functionality is given just by this test objectively. And most commonly, you would want to order it when your symptoms and the signs are not matching. The patient's symptoms are more, but you are not seeing anything, or there are no symptoms, but you are seeing a lot of things. So in a child with wandering eye movements, you would want electrophysiology to know what is the problem, whether it's in the brain, whether it's in the eye, in the retina, where the problem is. When a family history of inherited retinal diseases, to check for integrity of the visual pathway, and when you have media opacities, whether you should operate on that patient or not operate. To monitor certain drug toxicities, it would be important because certain drugs cause toxicity specifically in the retina. And to monitor response to treatment where you are treating certain inflammatory diseases, and now with the gene therapy coming in, to monitor response to treatment to gene therapy, this would be very important. So since we are talking of objectivity, it is very important to have some standardization. So that is what is given by the ISCEV, that is the International Society for Clinical Electrophysiology of Vision. Their work is just to give you basic standards of your machine, what parameters your machine should be working on, what parameters your electrophysiology room should be working on. so that you get the same recording, whether it is recorded in India, whether it is recorded in US, in Russia, anywhere you get the same recording and you can talk the same language. So that is given by the ISCEV. It's very important that you go to their website, read the articles, they are freely available on the website, and you learn about these tests from them. So coming to the electrodiagnostic tests and what they test, so this is basically a visual pathway that we have. We have the retina, we have the pathway going from the optic nerve right up to the visual cortex in the occipital lobe. So we need to test each component of this pathway one by one, and that is what electrophysiology is going to give us. So starting with the layers of the retina, first we have the RPE, that is the outermost layer of the retina. So the electrooculogram is a test that gives us the capability to test whether the RPE and the junction of the RPE with the photoreceptors is functioning correctly or not. Then coming to the main layers of the retina, the full field ERG is a test which will give us the capability to test the 9 layers of the retina, whether they are functioning correctly or not. And we will come to detail further as how we can differentiate between the outer retina as well as inner retina on the basis of the ERG. Now full field ERG is a full field, basically covering the whole of the retina. Sometimes we want to test just the fovea or the macula. So for those we have the multifocal ERG, which will give us information specific to the posterior pole. And then coming on to the ganglion cells and its connections with the retina, that is tested by the help of the pattern ERG. So we have covered the entire retina, and then the whole visual pathway is basically tested with the help of the VEP, that is visual evoked potentials. So visual evoked potentials are testing everything, right from how the light is entering into your eye, whether your refraction is correct or not, whether you have a corneal opacity, whether you have a cataract. Everything is going to have an effect on the visual evoked potentials and not just a cortical lesion. So visual effect, coming on to specifically to the visual evoked potentials, they are very sensitive. They will tell you, yes, there is some problem in the visual pathway very nicely, but they are non-specific. You can't pinpoint the lesion where it is just on the basis of a VEP. It is a good screening test to start with, but it needs other tests in conjunction to rule out the other things so that you can pinpoint the problem onto one particular thing. So this is typically how a patient would be tested for VEP. You have the gold cup electrodes where the active electrode goes near the visual cortex, the reference electrode on the forehead, and the ground electrode which is again attached to the top of the head. And the patient sits in front of a screen which give him different kind of stimulus, and you get some waveforms. So there are different kinds of stimulus that may be possible to be given with visual evoked potential. The most commonly used is this checkerboard pattern with a pattern reversal VEP, in which this pattern reverses, the black becomes white, the white becomes red. It's a contrast stimulus, and you get a good waveform and you get very accurate testing of your whole pathway. There is some other thing called as a pattern onset offset VEP. This is mainly used when you want to test patients who do not have a stable fixation. Somebody who might be malingering, you want to test it with a pattern onset offset so that he doesn't know when the pattern is coming on off, and you can record the signals accordingly. Also in some patients with nystagmus, this might be helpful. And in patients who can't maintain fixation, then we are left with no choice but with the flash VEP. It is a very gross response. It just tells you whether any signal is going forward or not, and nothing more than that. So this is a typical VEP waveform that you would get from a pattern reversal VEP. It has a N75 negative wave and a P100. This just corresponds to the time frame when these waves should be coming in a normal VEP. So you would want to look at the peak time when the peaks are appearing, whether they are appearing at the right time or not, and also the amplitude, that is the height of the P100 from the N75. And these would be important in diagnosing various conditions, whether the VEP is normal or not. So the points to remember for VEP are: records the response from the entire visual pathway. Readings can be affected by a host of factors: improper refraction, media opacities, macular disease, optic nerve disease. So to pinpoint the cause, you need ancillary testing, you need your clinical examination and other tests. And retrochiasmal lesions, basically they will need a multi-channel VEP. There are single channel VEPs that we mostly use in ophthalmology. They are going to test up till the optic nerve. Beyond that, they can't test because your fibers crossed. They are going to give you a signal whether it is reduced or not, but they won't be able to pinpoint the problem. So retrochiasmal lesion need multi-channel VEPs where you can get signals from both the lobes separately and try and separate the signals. So coming on to the retina, that is the electroretinogram that is going to tell us about it. There are three types that are possible, as I told you. The first is the full field ERG, where you use a Gans field. Gans field basically means the whole field. So the patient sits just like a visual field testing. It sits in front of the Gans field with the chin inside, and the whole of the retina is illuminated by the Gans field with a very specific intensity of light, so that you know that you are testing the same everywhere, and it gives you a mass response of the retina. Again, you have an active electrode which is touching the cornea or the bulbar conjunctiva, and in some uncooperative patients maybe on the skin, on the eyelids. And then you have a reference electrodes that is on the zygomatic fossa, and the ground electrode which is on the forehead. And again, you can have, to test specifically the posterior pole, you would want to do a pattern ERG or a multifocal ERG as the indication may be. So these are the various types of electrodes that are available to test the to conduct the electroretinogram. The most sensitive is the DTL electrode, which rests on the bulbar conjunctiva. And there are some contact lens electrodes also available which are in contact with the cornea. So they give the highest voltage, but the repeatability is a little bit less. And also when you are doing a pattern or a multifocal ERG, you would want an electrode that is not coming in your visual pathway. So contact lens electrodes cannot be used for recording multifocal or pattern ERG. You want a clear visual pathway with a good refracted patient. So for that, the gold foil or the DTL electrodes would be ideal. And the reference and the ground electrodes come with the gold cup electrode. So this is a typical waveform that you would get from a full field ERG. It will have a negative A wave to start with, and then a positive B wave to go on to. So you have to remember, it evokes the response of the entire retina. So if you just have a maculopathy, your ERG is likely to be normal. So the A wave is coming from the rod and the cone photoreceptor cells. So we are trying to differentiate the retina further in between. So the outer retina, that is the photoreceptors, that is being represented by the A wave. And the B wave is coming from the bipolar cells, that is the inner retina. So if you have a A wave that is not coming properly and a B wave coming properly, that would rarely be there, because photoreceptors, once they are affected, they would affect the B wave also. But A wave is specific to the photoreceptors. But you can have dysfunction that is just in the inner retina, and in that you will have just the B wave that is flattened out and a normal A wave. We will come to a couple of examples of that later. So this is this ICEF minimum standard recording that you have to do. You dark adapt the patient for 20 minutes. You take a dark adapted 0.01, a dim flash ERG. It is so dim that the cones are not excited at this intensity. So whatever response you are getting is entirely from the rods. So this is the only one that gives you the response only from the rods. And then you have a flash with an increasing intensity is going up to 10, where you can get both the A waves and the B waves. So both these have contribution from both the cones and the rods, but they are majorly driven by the rods. So then on the ascending wing of the B wave, you have some of the oscillatory potentials which are taken out and represented separately, and they mainly indicate function of the amacrine cells that are between the bipolar cells and the photoreceptors. And then you light adapt the patient for 10 minutes in the Gans field, and then you record your light adapted ERGs, which again have similar waveforms but give you functionality of the cones. The flashes in this are so frequent that the rods are not able to get back to their resting potential to give a signal into that. Only the cones are able to do that. So these are testing just the cones. So abnormalities, as you can see, the normal waveforms we talked about. So if you have a macular dystrophy, you can see you have a normal kind of B wave, you have a normal dark adapted thing, maybe some reduction in the waveform, but you see the waveforms are pretty well maintained, because the full field ERG is testing the whole of the retina and not just the posterior pole. If you have a cone dystrophy, you get the good dark adapted responses because your rods are normal or will be affected later, and you see that you don't have any responses in the light adapted stage. And if you have a rod cone dystrophy, that the rods are affected more profoundly than the cones, you have almost flat dark adapted but some signals coming in the light adapted stage. So basically when you are classifying dystrophies, rod cone or cone rod, it is on the basis of your full field ERG, what kind of response you are getting. So coming on to the multifocal ERG, it is a technique that allows electrical signals from multiple discrete areas across the posterior pole to be represented, and it is a topographic representation. Just like you have in the visual fields, it is a topographic representation. So you can actually pinpoint which area is abnormal and then monitor whether that abnormality is extending beyond that point or not. The waveforms are not actually the same, as this is just mathematically derived. It is a very small signal that comes. So this is the kind of abnormalities that you could get on a multifocal ERG. Here you can see, except for this central area, the entire waveforms are flattened out. So this is kind of a rod cone dystrophy with macular sparing. And here you would see where the entire waveforms are normal, but the waveforms are just flattened out in the center. So this could be a macular dystrophy or a cone rod dystrophy, which is affecting first the center primarily. And also you could have focal abnormalities here and there. So multifocal ERG is very important in monitoring drug toxicities, especially HCQ toxicity that we most commonly talk about. Coming on to the pattern ERG. So it is a contrast stimulus which tests the retinal ganglion cells. But then again you have to understand, this is the classical waveform that we get from a pattern ERG. For a pattern ERG, the patient has to be refracted and has to focus on a single point. If a patient cannot focus on a single point, has very low vision, a pattern ERG may not be possible to be performed. So you have the P50 component and the N95 component in a pattern ERG waveform. Both the waveforms are coming from the ganglion cells, but the P50 component is derived by the macular photoreceptors. So if your macular photoreceptors are going to go, the P50 component is going to go down, and subsequently obviously the N95 will also go down. The N95 is derived entirely from the retinal ganglion cells. So if you have a disorder that is affecting the retinal ganglion cell, you will have a selective loss of the N95, the negative component of the waveform, and the P50 component will remain normal. So diseases like LHON, retrograde optic neuritis, that is going to affect your ganglion cells, they will affect selectively the N95 component of your pattern electroretinogram. So just this, we talked about this when we were seeing the full field ERG. So let's see if we add the pattern ERG to these, what do we get? So again, in normal, you get a normal pattern ERG. If you have a macular dystrophy, you can see your pattern ERG is flattened out because your macular photoreceptors are gone. If you have a cone rod dystrophy, again your macular photoreceptors are gone, your pattern ERG is gone. But if you have rod cone dystrophy where your central part may be relatively spared, the pattern ERG is reduced, but it's giving you a good waveform. Again, when we come to optic nerve disorders, you can see optic neuritis, right eye, left eye normal. Here you can see that the waveform is reduced in the affected eye, but the selective loss of the N95 component is visible in the affected eye. And similar would be a case of non-arthritic AION, where you can see the waveform is, the pattern VEP is flattened out, and the pattern ERG shows a selective loss of the N95 component because your ganglion cells are getting affected, but the macular photoreceptors are normal. So points to remember about ERG: can record an activity from the entire retina, hence a focal macular pathology may be missed. Full field ERG, a wave gives photoreceptor, outer retinal, A wave gives you the outer retinal function, and the B wave gives you the inner retinal function. And macular testing is possible with multifocal and pattern ERGs, and good fixation and refractive correction are essential for the macular ERGs. And again, for the pattern ERG, as we just said, P50 gives you the photoreceptor function, and the N95 gives you the ganglion cell function. So coming to the last one, that is the electrooculogram. So this is for the RPE. It records the potential across a RPE cell from the cornea, from your eye surface. So what is commonly talked about the Arden ratio, in this the patient is dark adapted for 15 minutes and is given pulses of light in between, and the patient has saccadic eye movements in between to the various points of light that are shown to the patient. And then again 15 minutes of light adaptation. You have a trough, the potential going down when there is the dark adaptation, and the peak coming when there is light adaptation. And the ratio of the light peak to the dark trough gives you what is called as the Arden ratio. The normal range is 1.7 to 4.3, and anything 1.6 or less is considered pathological. So, but what you have to remember is EOG is of value only if your ERG is there along with. If your ERG is abnormal, if your photoreceptors are not functioning correctly, your EOG will come abnormal. So you have to have a full field ERG along with before you do an EOG. Only then you can interpret the EOG further. So Best disease, where this is most commonly used, it is diagnostic only if you have an abnormal EOG with a normal ERG. And EOG is normal in the adult onset vitelliform disorders. So this is a algorithm given how to go about testing. You can read about it in the article that I have given in the reference. So let's just put this knowledge to use in a couple of case examples that how this helps us. So this is a very simple one. You see a 40-year-old man, low vision in the left eye following road traffic accident, suspected indirect optic nerve injury. You have done your examination, the ocular part is normal. So this is very clear. You can see the normal N75 and the P100 components coming in the right eye, and in the left eye both the amplitudes are also reduced and also the N75 and the P100 are delayed. So that indicates optic nerve damage in that eye. So that is pretty diagnostic in this case. So this is a patient now, she's came to us way back when she was 1 year old, came with nystagmus. You can see the patient can barely open the eyes in light. She's not opening the eyes, she's very photophobic, and that was the primary complaint. So she had nystagmus that kept on reducing. We were not able to diagnose what is happening. Every time we would used to see the retina looks normal. Too young to get a ERG, probably didn't do it at that time. So now the patient is 5 to 6 years of age. So this is the fundus that I'm going to show you of the patient. It looks absolutely normal even now. This is now. It's hard to find an abnormality in the fundus right here when you look at it clinically. So, but when you do the full field ERG, what do you see? You see the normal B wave coming in a dark adapted dim flash ERG. You see a good dark adapted bright flash ERG, but the light adapted ERGs are almost flat. So there are no cones present in the patient. So this is a patient of achromatopsia. So this kind of proved our case, and also the genetics kind of helped us further confirm our diagnosis with a CNG-B3 compound heterozygous pathogenic mutation in the patient. Coming on to another case. Now again the fundus, there is some glow on the fundus. There is some kind of atrophy in the center. You do autofluorescence, we just talked about. It helps us a lot. You see this kind of Robson holder rings that are there in the fundus. But I don't know if you can tell which area is abnormal. The central is abnormal or the peripheral is abnormal. The rings are at the margin of the normal and the abnormal. But you do an OCT, you get more information. You see that the central photoreceptors are gone. The photoreceptors are kind of ending over here. So the ring is at the margin. The central part is abnormal. The peripheral is normal, apparently looking at this. But the patient says to you he has a problem in night vision. He does not have a problem in day vision. He has more problems in night vision. So you go ahead and do an ERG. So what you see in an ERG, that your B wave is reduced, your dark adapted ERG is again diminished, and when you see your light adapted, they are relatively normal. They are also reduced, but you are getting a good waveform. They are relatively normal. So this kind of proves that the patient is not lying to you. This is a kind of rod cone dystrophy with early macular involvement. So that is why you are this kind of thing. And that is what came on the genetics. The patient was positive for RP2 mutation for X-linked retinitis pigmentosa. Again, a likely pathogenic mutation. Another one, a 7-year-old child brought by parents, low vision at night. Again, night vision problems. Vision is 6/6. This is the fundus. Anybody wants to take a guess? Looks absolutely normal. except for maybe a little bit of golden sheen on the fundus looks normal. The OCT is absolutely normal. There is nothing to suggest that this patient might have any problems. The autofluorescence also was completely normal. But when you do an ERG, what do you see? A full field ERG. The rod response, the dark adapted responses are completely flat, they are diminished. And even the bright flash ERGs are reduced in intensity, while your light adapted ERGs are showing you a normal waveform. So this is what is called as congenital stationary night blindness, in which the fundus appears normal, but the patient has night blindness. So what you do in them is basically you increase your dark adaptation time. You'd give them a longer dark adaptation. We were doing for just 20 minutes, give them for 4 hours, 6 hours, even 24 hours people have shown. So this is after an extended dark adaptation of 4 hours. This kind of proves your diagnosis. Your waveform, which was this high, has become this high. So there is an increase in the availability of the rods after extended dark adaptation. And this case was a case of Oguchi's disease, what you talk of the Muzio-Nakamura phenomena. After the extended dark adaptation, the color of the fundus also changes. From this golden sheen fundus, you get back to a normal colored fundus. This is the Muzio-Nakamura phenomena in Oguchi's disease. Again, ERG helping you with it, and again genetics supplementing your diagnosis with a pathogenic mutation. And of course, you go on to the families and you test that also. Now, just to show you the differentiation between the retinal layers. So this is an 8-year-old boy, generalized low vision. There are no doubts in the diagnosis. When you see this large schisis cavity, in the periphery, and you see this spoke wheel kind of pattern at the posterior pole. This is a case of X-linked retinoschisis. So you don't have any doubts to the diagnosis, but 50% of the patients will present to you when they don't have peripheral schisis and very mild schisis at the posterior pole, or may not be present. So it is difficult to diagnose these patients at that time that why they have low vision. But once you do a full field ERG, what do you see? You have a very normal A wave coming, but there is no B wave. There is no positive component to this dark adapted ERG. So that shows you that this is an inner retinal dysfunction. There is schisis that is present in the inner retina. So the B wave is absent and the A wave is coming normally. So coming on to my last case, I think. So this was a 14-year-old male who presented to us with blunt trauma in the right eye. So you can see the retinal detachment in the right eye and a large dialysis inferotemporally. That is not of concern. The problem was what we were seeing in his left eye. So we were seeing this kind of lesion at the posterior pole in the left eye. The patient was 6'9", he was not complaining in that eye, but it was an incidental discovery while we were seeing the other eye. This is the autofluorescence of the patient. You see that hyper autofluorescence of that lesion, which is very characteristic of vitelliform deposits. And even in the right eye, you can see some hyper autofluorescence of probably that deposits that were there in the center, but now because of the detachment have gone down. And you see this vitelliform kind of deposit at the posterior pole. So is this Best disease? The patient is not complaining. You do a EOG and you see that yes, the ERG was completely normal in the left eye. Right eye obviously had a retinal detachment, so that was abnormal. And once you see that your Arden ratio is 1.4, that kind of pushes you towards a diagnosis of Best disease. You get the genetics done, and yes, it confirms your diagnosis of Best 1 gene. So to conclude, just make sure that the tests are done as per the prescribed standards. That is the most important, because it is an objective assessment. Ascertain the origin of the signals. You have to remember what is the origin of each signal and interpret accordingly. Correlate with the history, symptoms, ocular findings, imaging, and the family history. It is very important to take the whole picture. You just can't have a printout and hand and make a diagnosis. And just remember that electrophysiology is the only truth. To make make the diagnosis fit into the electrophysiology and not vice versa. Don't try and make a diagnosis and then send for electrophysiology, okay, this will be like this. And once again, I would leave you with this slide to let you remember the origin of these signals. Thank you very much.
Thank you, Simar. And also to add to that, the only thing about electrophysiological tests is that no matter how many ever times you learn it, you will tend to forget it. because
You have to
that's what
keep doing it.
Yes, unless you keep doing it, unless you keep practicing the art of reading the tests, advising the tests relevantly, I think it's a tough call. Very well done. And I think you practice the pediatric retina also a lot, so you're so well versed with all the tests and how to interpret them.
It comes in very handy in the children.
Yes, yes, especially. So thank you, Simar. If any other no doubts, we can go to the next talk. Okay. So great privilege to invite on stage Dr. Lalit Verma. As you're all aware, he's the president of the All India Ophthalmological Society, and a real privilege to have him on stage. He's an excellent teacher, and every time I listen to him speak, I learn something new. So I'm sure it's going to be a treat to hear him speak to us about vitreomacular interface and its disorders. Over to you, sir.
Thank you, Chaitra and Obli. Thank you, the entire family of CFS, for arranging this wonderful teaching exercise, specifically Santosh, Rashman, Rolika, and so many other people who are involved in this. Wonderful, one of the most, illuminating talks by Simar I heard on electrophysiology. I think all of you should take back these notes and, as Chaitra was saying, practice. So I'll talk something about VR interface disorders. And this is my favorite slide actually, because I always start with, whenever any fellow comes, by OCT ki layers gino aap pehle. You see, a lot of people spell ophthalmology wrong, H they always miss. OCT may be 10 layers, very difficult, everybody may not. So even if you know, I'll still read out. We start from, you see, from ILM to RPE, and that's the way I counsel my patients also, that yahan se nazar aata hai, this is the line which is most important, which is the layer of rods and cones, and then you have external limiting. These three lines you should always remember, this external limiting membrane, then rods and cones, and RPE. Because if these three lines are preserved, the patient will have good vision. Even surgically, we always talk whether integrity of these three lines, whether it's a DME, vascular block, or other pathologies, ARMD, these three lines always remember: ELM, ISOS junction, and RPE. Then comes outer nuclear, outer plexiform, inner nuclear, inner plexiform. And then is the ganglion cell layer, and here is the ILM. So remember, from ILM till RPE, there are 10 layers of retina. And if you classify on OCT pathologies, we have inner pathology and outer pathology. The outer retina extends those three lines which I told, ELM to RPE, whereas inner retina means from ILM to these two membranes, ILM and ELM. These are inner retina. So diseases which are, of outer retina, which have been told also, is primarily ARMD, PCVs. With inner retina, the diabetic pathologies as well as the vascular blocks, they come in the inner retina. So once you are reading OCT, do not become a consultant and write, edema plus, and then you will falter. You will falter. Always focus your eye whether outer retina is okay or not, inner retina is okay or not, and then comes the junction. Junction is where vitreous meets the ILM, where there is a contact between vitreous and retina. So I'll primarily talk on junctional pathologies. To begin with, I'll just start how we are born. We are all born with a 100% gel vitreous. Gel vitreous means something like consistency of a white of an egg. It's a lacy kind of substance. And this normal cortical vitreous is adherent to ILM at various places. You see, what happens with age and other factors is whether disease, trauma, diabetes, two things occur. One is that vitreous, which is gel-like, becomes sol. Sol means they get liquefied. Another thing is attachment of the vitreous to retina gets weakened between the cortical vitreous and the ILM. So if both these processes, that is liquefaction as well as adherence, occur concurrently and completely, that means 1 and 2 occur completely, then what you get is total PVD. And in this process of total PVD, you may have F and F, means flash and floaters may occur. And during this time, retina may get torn, you may get a horseshoe tear, or something may happen, or something may not happen. But if vitreous gets liquefied and adhesions are still plus, so this will allow this liquefied vitreous to gain access to the retrohyaloid space. And this initiates a process of PVD, which is not complete. So this we call as anomalous PVD. And this itself is a stimulus for cells to proliferate. And this process can be accelerated by breakdown of blood-retinal barrier, by trauma, by disease. And here comes the role of cells which proliferate under the hyaloid and which cause membrane formation. So this, if you understand this, the whole lecture becomes very easy. That this anomalous PVD is what we call incomplete PVD, and this explains whole lot of junctional pathologies, which includes VMT, VMA, epiretinal membranes, and macular hole also. So this classification, I think all of you should remember, which is IVTS classification for VMA, VMT, and macular hole. And the salient points to be remembered here are this 1500 micron. VMA, if it is focal, it is 1500, it is broad-based, then it is more than 1500. Same is true for VMT, depends on the size of attachment, that is 1500 versus more than 1500. Full thickness macular hole, again, three things we should remember is small, medium, and large. 250 and 400 are the figures you should remember. Anything more than 400 is classified as a large macular hole. And anything less than 250 is small. Although in our clinical practice, we rarely see small macular holes. We always see extra large macular holes. Most of the macular holes we operate, they are 1000 microns or 1400 microns. But internationally, you should know 250, 400, and this is the. Also, you should know that definition of full thickness macular hole is full thickness foveal lesion from ILM till the RPE, which 10 layers I show. Lamellar macular hole is defined as irregular contour with defect in the inner fovea, but intact photoreceptor layer, because it is not extended up to the photoreceptor layer. And pseudomacular hole is because of the concomitant ERM with central opening and heaped up foveal edges. So this definition also you should know. What is full thickness, what is lamellar macular hole, and what is macular pseudo hole. Pseudo hole always say it's because of primarily ERM. So we'll just touch upon these pathologies, VMA, VMT, ERM, and macular hole. So VMA is, when the vitreous is separated as is shown in this figure, but remains adherent here. But there is no element of pull onto the retina. And since there is no pull, generally the patient is asymptomatic. And if it is pull, then it is known as VMT. If you see figure on the lower right side, this retina is getting pulled up now. So this is known as VMT. This is not VMA now. This is converted to VMT. And once imagine that if the retina is getting pulled up, so all the layers are getting pulled up, then you may have metamorphopsia. Metamorphopsia means teda meda dikhega mareez ko. That is very important. And then long standing may lead to decreased vision and cystoid macular edema. So difference between VMA and VMT is primarily pull. And since it is pull, photoreceptors are getting pulled up and you may have metamorphopsia. The key question comes is, diagnosis becomes easy once you see OCT, but what do you do after you diagnose these things? So all OCT diagnosed VMT does not require treatment. Sometimes it may be an incidental finding also. And a lot of these patients may complain of occasional metamorphopsia, tolerable, tolerable metamorphopsia. Patient will say, Doctor, kabhi kabhi hota hai, occasionally it happens, but it does not hamper their day-to-day lifestyle. And therefore, this does not require any treatment. Sometimes, if patient is lucky, you are lucky, this may detach completely and you may have complete PVD. So I will show you one example. This eye, right eye, I had operated for macular surgery, fortunate to have good vision. But left eye, patient was not aware of no complaints at all. So this was the picture of left eye. You see there is a clear-cut VMT here, but believe me, this patient still today, more than 10 years follow-up, does not have any complaint at all. So this is an asymptomatic, so therefore does not require intervention. So all OCT diagnosed pathologies do not require surgical intervention at all. So this was one patient, you start from the February 2016, there is an element of VMT, increased, patient started complaining of near vision problem and metamorphopsia, but once I had counseled him for surgery, before surgery, this vitreous got detached. You see this layer got detached. So BCVA improved to 6 and 6, and there is spontaneous resolution of VMT. So this may also happen sometimes. So management of VMT, again to revise, is only if the patient is symptomatic, patient has intolerable metamorphopsia. Even though vision may be 6/9 or 6/6, but if patient disturbed by metamorphopsia, it's a very annoying kind of symptom, you may intervene. And other indications could be decreased vision, CME, and macular hole formation. So remember, we do not treat OCT. Our aim is to treat a human eye. That means patient has to be symptomatic. The right eye photograph shows Right side photograph shows an alarming kind of VMT, but patient has 6/6 vision. So management is to remove this, this vitreous phase or the green colored on pseudo color hair, to remove this traction. Aim is to remove this traction, and then automatically the contour may come back. And all of us have been doing vitreous surgery for a long time, and results are one of the most gratifying kind of results. And MIVS is the choice today. But in between, a decade back came this injection Jetria. Jetria is known as ocriplasmin. Nearly, October 18th, 2012, it was launched by Thrombogenetics. It causes enzymatic vitrolysis. It causes vitrolysis, and patient may have improvement. And ocriplasmin, this was studied in MAVI trust trial. The reason it causes improvement is it has a proteolytic activity against various protein components at the interface, namely laminin and fibronectin. So since it dissolves at proteins, it can lead to separation of this. But it came with a big bang, but it disappeared also with a very big bang, primarily because of 3-4 reasons. It was very expensive. One injection is $4,000, and the success rate is 25 to 27% only. Whereas with the MIVS, success rate is nearly 95% to 100% virtually. And complications which were not related in MAVI trust trials, post-marketing, you had issues like darkening of vision and disruption of ISOS layers and ERG reduced wave. And the reason all these complications occur is because ocriplasmin is not specific for any place. It cleaves the laminin fibronectin all across the retina. It's a pan-retinal dysfunction, and therefore there are issues on ERG and OCTA. And this was another study which compared ocriplasmin versus vitrectomy, and notice wherever vitrectomy was done, the result was nearly 100%, and wherever this was treated with ocriplasmin, VMT resolution was dismissal, that was around 50%. And as I said, you begin with MIVS 25 gauge, and PVD induction is the key step. And most of the times, after you do core vitrectomy, we put some crystals of triamcinolone, and let me show if this video works here. Okay. So this is what we do here. So after we have done core vitrectomy, we put this triamcinolone, and typically two round circles will form, one on the optic nerve head and one on the macula. And then gradually you increase the suction. Never increase suction suddenly. It has to be gradual from 150 to 200 to 300. And be very careful that you do not cause any iatrogenic issues. And the last end result is, end point is the signet ring formation, which means that from the disc you have taken out the entire attachment of the vitreous. And this is followed by air fluid exchange. We do not inject gas also in such situations. No C3F8 or SF6 is required. This is one example of this patient of VMT, and notice how this contour comes back. But believe me, this contour takes months to come back. It's not that you operate and within few days it comes back. It takes months for this elasticity to come back and go back. So you see this, the reason I am showing this video is, this is an alarming kind of VMT on the upper right side, and if you pull too much, this can cause macular hole. Iatrogenic macular hole can occur. So therefore, once you are operating, patients who have this very severe tenting, do not pull too much. And what I do in such situations is PHF trimming. Trimming means you go all across, that is foveal sparing surgery you have to do. We are going all across the macula, and at the end, you will go towards the papillomacular bundle and leave this stump hairs. You can see this stump here, triamcinolone stain, and you will not pull this, otherwise there can be iatrogenic issues. So this was the result of this patient, which I showed this OCT, and again this patient did improve. The air bubble is still inside once we took this photograph. This was another patient. Only this PHF trimming was done, foveal sparing PHF, and no ILM peel also. This is another example to show that patient improved from 3/60 to 6/18 with only a small surgery which takes around 10-15 minutes that you do PHF trimming. The other pathology is about the epiretinal membrane. Remember these three membranes in the retina, PHF, then ILM, and one is the membrane upon the retina. Epi means upon. So in VMA and VMT pathology is PHF. In macular hole, in addition to PHF, it is the ILM which is at fault. So therefore, in all patients of VMA and VMT, we may not remove ILM. But in macular hole, ILM removal is a must. And epi means membrane upon the retina, means epiretinal membrane. So what we do in epiretinal membrane is that after we have removed the hyaloid with the help of triamcinolone, we go ahead and generally stain this epiretinal membrane. And this stain generally comes very well with the trypan blue stain. And aim is always to identify the edge, because once you identify the edge, then the job becomes simpler. It's very important to position your instrument between the healthy retina and this abnormal retina. And you see this, this MVR blade is being used here. And then generally this epiretinal membrane will come in a single sheet. Very rarely you will have problems. And this you can peel it off and see the surface of retina. If surface of retina is smooth, then you come out with air fluid exchange. And again, you do not need to inject any gas in such situations. So this is another example of a patient who has had epiretinal membrane. So here what we do is again, first membrane to remove always is hyaloid with triamcinolone assisted. And then what I do is I do an air fluid exchange in this phakic eye, make the posterior pole dry. And once it is dry, under air, you put 1 or 2 drops of this dye, that is trypan blue, and wait for a couple of minutes, and then remove this dye under the air itself. And once this dye is out, my favorite instrument is 25 gauge bent MVR blade. This is the 25 gauge blade. Again, tease this epiretinal membrane. You see PHF has already been removed, and this membrane, after you have identified the edge, then take this, any end opening forceps, Packard forceps is being used here, and this membrane will come out as a single sheet. Here again, I did not remove the ILM in this patient. So this is the result of this patient. A lot of these macular surgeries are combined with cataract surgery also, because the patient has post-op development of cataract in these patients. As I said, ILM peel in pure ERM is not a must. You should always try to remove it, because the advantage of ILM peel is that it ensures that all the membranes anterior to have been removed, and there are reports which say that post-operatively, ERM formation is less. But global trend says that ILM peel in a pure ERM is not advantageous from the vision point of view. The last thing we have to cover is about the macular hole, and all of you know that evolution of macular hole has been, since the time of macular buckling, and then, a lot of people used to do only pneumo procedures, then some funny people tried laser also, but ultimately it is the ILM which made this revolution. And since the time, Kelly and Wendell were the people, 1991, they did the first vitrectomy and did an air fluid exchange. At that time, ILM peel was done, and the result was also not very much, and strict face down position. And reported success was around 50% only. And since then, a lot of modifications have been done. Biological adjuvants have been used. TGF beta, I remember one of the American Academy meetings, TGF beta caught the fanfare, but it did not stood the test of time. What stood the test of time was the ILM peel, and success rate immediately improved from 50% to nearly 96% in the anatomical pathway. And steps include, you see, a complete PPV, then take care of the hyaloid phase, and then inject. Let me show this video here. So this is the video of ILM peel. This dye we used here is BBG. BBG is also known as blue ICG. So after vitrectomy has been done, we inject this PBG dye, wait for a couple of minutes, then scratch the ILM. This is a diamond dusted scratcher being used, but no longer I use this. This is one of the older videos. We directly take the Packard forceps and pinch the ILM. And what is being shown here is the ILM peel, where you take this ILM across the macular hole. That means you peel and take across the macular hole, and after that do an air fluid exchange. So this is the result of this patient. You see type 1 closure after 4 weeks, 6/24. Here we generally end up injecting gas. There are a couple of more patients showing type 1 closure after macular hole surgery. And there has been, about type 1 closure, type 2 closure. Type 1 closure I showed you where there is no neurosensory retinal defect. Type 2 closure is, it's a closed hole, but there is a neurosensory retinal defect still present here. So this is photographically shown. Left eye is type 1 closure, pre and post-op, and this is post, with type 2 closure. A lot of indices have been given in books, which is known as hole formation factor, macular hole index, and minimum diameter on the OCT. You should know these indices because you could be asked sometimes. And what is hole formation factor, which was given by Pulifiato from Boston, is that you C and D means the lateral, you plus C and D, and then divide by the basal diameter, C plus D upon A. So if the hole formation factor is more than 0.9, possibility of closure is very, very high. However, if it is less than 0.5, the possibility of closure is less. Meaning thereby, if it is a vertical hole like this, it will close easily. However, it's a hole like this, where the height is less, but the base is more, then possibility of type 2 closure may be there. Other is this macular hole index, which is very simple, that is height upon base diameter only. It again has a good correlation. The third is minimum diameter on OCT. So a lot of people have been scaring, patients that, ulta letna padega, ek hafta, 2 hafta, but normally it is not required. 1 to 2 days is good enough, or even position like this, a sitting position with the, face down is good enough. A lot of patients are obese and can't maintain, but sitting face down, reading position is good enough for closure. So this is example where all the 3 membranes were removed. That is, patient had initially tricot assisted PHF removal, as is shown here, gradual increase in suction. After that, we did an airflow exchange, put this few drops of trypan blue, wait for 1 or 2 minutes, remove excess of trypan blue, and then with the help of 25 gauge, identify this epiretinal membrane here. Very, very carefully, because most of the time has to spend in identifying the edge of the membrane. And then you take hold of a card forceps, remove this ILM. And notice there is a lamellar macular hole here also. And once this ILM was out, the surface of the retina was still wrinkled. And since it was wrinkled, so I thought I will remove the ILM also. Then injected the third dye now, that is the BBG dye. And this is the staining. You see, after the ERM has been removed, the entire ILM is very well stained now. And in this patient, I made a flap rather than the peel. And this was the result of this patient. This is the OCT. This was the pre-op 6/24 and post-op contour trying to come back, but not still come back. See, these 3 lines are intact, and that is the reason patient has 6/6 vision. 2016 was a game changer. Game changer means you see this ASRS conference, a lot of presentations were there where ILM flap was talked about. Flap means you don't peel the ILM across the macular hole. And this was the presentation done here by Myclaska, where ILM flap technique was described. And they had, presented this, that closure in peel was around 88%, where in flap it was 98% closure, which they had seen. So this was one of my first patients when I did, after coming back from this conference, where we, instead of, peeling, we had this flap. This is known as direct pinch and peel. No use of diamond dusted here. So you create this opening of the ILM, and instead of sweeping across the hole, just leave it at the edge of the hole. You see this flap has been left at the edge of the hole. Multiple such flaps can be taken, or only you can have temporal flap or a mini flap. A lot of variations are available. So here we have just left this here, and rest of the ILM still. This is a macular flap. And at the end, what we'll normally will do is just to trim it so that it's not such a big flap. And this is the end result of this patient. It's a, type 1 closure. Notice the hole diameter is 1467. It's a extra large kind of macular hole. This is another example of a vertical hole like this. If you do a routine flap, it may not close. So, but with ILM flap, there is all possibility of this 951 also closure. This is another patient of ILM flap done long time back, 2018. In myopics also, you see myopics also it is advised that instead of doing a peel, you should preferably do a flap. This is another, 1700 diameter flap. This is one of my last videos now. This was a patient who had ILM surgery done. So in this patient, you see, since ILM had already been removed, so you have to, take a ILM graft from extramacular area and put it. And if you do in a fluid-filled eye, this graft will keep moving. So you have to do under the PFCL. So initially, we have prepared this graft near the disc area, and then you inject the PFCL because graft is lying here. And then under the PFCL, with the help of this diamond duster, you maneuver this flap so as to place it over the surface of hole. Like this. Once this graft is placed over the surface of hole, then you can remove this PFCL and do a airflow exchange. Be very careful, do it from the nasal side of the disc so that this flap does not move. Sometimes you can inject a drop of visco also there so that this basically means the graft should not move from its position. So world is today divided between peelers and non-peelers, and what is advocated is if it's a large macular hole, anything more than say 700-800, or it's a chronic macular hole, or it's a reopened macular hole, or it's a myopic macular hole, my personal choice is not to do a peel but to do a flap. So just to conclude, we started with OCT and various theories about complete PVD and anomalous PVD, and this explains all the pathologies which we have talked about. And Jetria, I do not think as of now has a place in the management, although company people still keeps pushing. Only place where you can observe macular hole is once a very small macular holes are known to close spontaneously, but the vision is 6/6. If the vision is 6/6, I do not enter this eye. But MIVS 25 gauge and staining agents for all the three membranes, as I said, has improved the prognosis tremendously. Thank you very much for your kind attention.
Thank you, sir. Fantastic talk as usual. I just have one question. Since you began with OCT and you went through the surgical, do you think intraoperative OCT actually adds, or just your skill is good enough?
I depend on my eyes rather than machine, actually.
Yeah,
not because I don't have, you see, it's a distraction for me. If, I am operating and I have to look whether I am holding the ILM or not, I will hold something else.
Yes.
I do not think it adds too much of value to, you see, you should depend on your rods and cones and see whether you are peeling it correctly or not.
Absolutely.
Rather than machine telling you whether you have done it or
Yeah,
not.
like sir said, it's rather distracting and it's not very easy to focus at all, because we recently had a demo. It was impossible to actually focus in an eye. When you're operating, look at the OCT, even though you have a heads-up display, it's rather difficult. But maybe for completion, to ensure that you've peeled completely all the membranes, it probably adds a little bit of value. But otherwise, like sir says, his skill is more than adequate. Thank you, sir.
Thank you. Thanks, sir.
Thank you.
Thank you so much, and I must appreciate the speakers and the chairs for keeping it absolutely on time. And one more request, all of you, the award session will be here within the next 4-5 minutes. So I request you all, even if you're getting up, please come back right away. Thank you. Thank you so much.